this became a very good treatment that they were able to get and opened up a new door for us just in the last year or so. But for people with pancreatic neuroendocrine tumors, it was a brand new treatment that was offerable that we were quite happy about, because for a lot of people, they don't want to take pills that have side effects. They don't want to take chemotherapy. These treatments, which generally are fairly manageable and have side effects, do quite well. This will open a brand new set of treatments for neuroendocrine patients that we didn't have before. So I'm very, very excited about that. There's another trial looking at PRRT in the United States. Some people know that I can take 2 injections, but I have found it works better sometimes with higher doses. And this study actually tests that. So that's quite good. We might have another option, not only PRRT, but we might also have an option of giving you double injections. Other so-called sunlight study, which looks at lanreotide versus a combination. What if we give a drug, an oral pill, plus the injection? Is that better? So again, a lot of new interesting trials coming up, and a lot of new options. I wanted you to take that moment and say that new trials are now being done, new options are available. It takes time, not as fast as we all want it to move, and I'm in that group that wishes things would move faster, but really, options are available. They're coming up more and more. That to me is exciting. So what if I have a pancreatic neuroendocrine tumor? What does that mean? That means you have a, people talk about pancreatic cancer. If we're fortunate enough to have a family member or friend who has pancreatic cancer, we know that it's a difficult disease and it's a very aggressive disease. Luckily, the type of pancreatic cancer we're talking about isn't as aggressive when we're talking about a neuroendocrine. So you can actually have a pancreatic cancer that's a neuroendocrine, or it's not the same as pancreatic cancer that the media talks about or Patrick Swayze had. It's really a different. What are your options then? Well, surgery is an option. Resective, that's very good. Resective, you can go back to that first option we talked about, maybe something different. And then we talk again about genetic medicine. I mentioned to you that the somatostatin analogs were useful for those injections that open a new door for pancreatic neuroendocrine cancer. And then there's some targeted therapies. So targeted therapies are pills, or can be injections, but generally they're pills that try to target the tumor, kind of like a bullet, a magic bullet that will go in and kill the tumor and not kill some of the other cells. It's not perfect, we're not there yet, but that's sort of the idea. I can tell you right now that no new chemotherapies are going to ever be developed. Chemotherapy, but the idea is moving forward is to try to So this is one trial that came out a couple years ago, and there was just an update in Europe that showed that these results were consistent, which looked at everolimus. Everolimus is a pill. It's made by This had such good results in pancreatic neuroendocrine cancer that it made sense to test it in all neuroendocrine cancer patients, and that's the big study that we're waiting for next year, which really could change the whole landscape of neuroendocrine cancer. But right now, for pancreatic cancer, this has already been shown. It's already had the phase 3 trial. It's already been approved by Health Canada. It's already approved for funding. Or sunitinib, made by Pfizer, and you can see here that again the results are very, very similar. If you look back at the everolimus trial and look at this, you can see the way the curves separate like that. That means that there's a massive difference. So both of them very impressive results. I can tell you that there is no studies like this in lung cancer and colon cancer showing such impressive results for both these trials. This is quite an impressive result that we're seeing. So we're actually making some serious headway here that hasn't been made before. Again, this drug is also approved now by Health Canada. It's also available for funding. There are some challenges in that the government will only fund one of the two, and it doesn't make sense. And Louise is not done which show that both these drugs are useful. We actually just are publishing right now, or have published, I think, a set of Canadian guidelines on CNETS. Really does mean is that it's being taken, going to be taken seriously. The better the journal it gets published in, the more seriously the paper gets taken, and the more people, when we take it to government for funding reasons, will say, because it goes to what's called a peer-reviewed process, where people blindly will read the recommendations and say whether this is worthwhile publishing. So it's kind of like, you know, getting published in, you know, the tabloid, or getting published in the Star or in the Globe and Mail, right? So it's kind of the same sort of thing. So those are being published in the Annals of Surgical Oncology. If anybody's interested, we can give them copies of that. So again, there's been no head-to-head comparison between these two drugs, and those are some of the questions that we're looking at answering right now. And we don't know by using biomarkers. That means we don't have any tests to say, well, these patients are going to do better with this drug, and these patients will do better with this drug. So how do we know which one is right for them? And I'm going to talk to you a little bit about that as well. One thing I do want to talk about is sort of what I say a rare cancer within a rare cancer. So this is, what if I have a high-grade NET? So we talk, mostly these tumors are G1 and G2. What if we're unfortunate and we have a G3 tumor? How do we deal with that? Do these principles still apply? Well, not necessarily. This is where targeted agents don't work, and this is where chemotherapy might work. And sometimes people read on the internet saying, well, you know what, chemotherapy doesn't work for NET. And generally that's true, there are exceptions, but a high-grade NET, or what we call a poorly differentiated neuroendocrine tumor, chemotherapy is applicable. And this is something that you know, you would find out quite early, because hopefully your physician would talk to you about that. And what it basically shows is that the high Ki-67, so this was a study that looked at Ki-67 above 55%. So that's why that number is so important. It helps us understand what treatment are, that these patients did really well with chemotherapy, or much better with chemotherapy, I should say. So that's why it's very important to have that number at the beginning to help understand. And sometimes that number can change. And sometimes you'll find that you need to do another biopsy to re-examine this. And the only reason we do it is to re-examine this number, because it can really guide treatment. I'm just going to quickly mention this. There is a new combination of drugs that's sort of being developed. We don't have that same level of evidence that I talked to you about the earlier drugs about. It's chemotherapy, and it's a pill chemotherapy, a combination of capecitabine and temozolomide. And some people may have heard of this or heard about this option. The data is coming through. It looks very promising. It's starting to come through. We can generally get access to it in the right situations, but I think we're going to hear more and more about this as time goes on. And then the ultimate question, what about PRRT? Well, you know, there's been a lot of talk about PRRT, and I see Dr. Izat's here, and I'm sure he'll give us an update later about this. But PRRT is radioisotope therapy, where you get basically medication or isotopes through the veins that hopefully stick to your tumor, and as the isotopes decay, they kill some of the tumor, and that's the general principle. Much more commonly used in Europe for sure. What I will say is there hasn't been as much evidence about PRRT as we like to think. And this is why I think, you know, when we are introducing PRRT in Ontario, it's going to be done in context of an evidence building or a clinical trial, that other clinical trials are being done in the States. And that's why in North America we haven't done it as much, because in a public healthcare system, or in a system where we need to have evidence to get these treatments, we need to either be doing it to collect the evidence, which I think we should do, or we need to have the evidence. And so there is some evidence that has shown that sometimes it works, sometimes it doesn't work. I don't think this is the treatment for everybody, and I just want to emphasize that. This is my view, and I think it's generally agreed upon that, you know, this isn't the end-all and be-all. This is a treatment option. These are all different options I'm giving you. This is one treatment option. For some patients, it's appropriate, but it's not the end-all and be-all. It's not a cure, and, you know, not everybody would want PRT. It has a lot of toxicity as well. I think Dr. Iza will talk a bit more about this, but just to give you an update that that's what PRT is about. But again, it's an option we want to have for sure. So what about clinical trials? What's happening about clinical trials? So you've heard a lot that sort of the way we move this forward, the way we get new options is through clinical trials, through research of understanding. So I want to talk to you a little bit about the NET research we're doing at Sunnybrook, and this is just some of the research that's being done. So what research is being done to stop the disease? Well, that trial, the big trial, Radiant-4, we had some of the largest numbers in the world, actually. I think we were the 4th largest center in the world in terms of the number of patients we had on the Radiant-4 trial. We're still waiting for the results of that next year. The trial has accumulated all the patients it needs. We're just waiting for the results to come through, and that takes time, so that's a big area. PRRT-wise, there is, I shouldn't have put this under Sunnybrook story, but the NETTER trial, we're waiting for that to come out. which is the other trial that I was telling you about, where patients are either getting the double injection or getting PRT. That will help us understand a bit more about PRT. And then we're hoping to participate, actively in the Ontario clinical trial when it's ready to go. We're opening up a trial. We're in the process of second-line PNETs. So we talked about those drugs, Sutent and everolimus, and I was telling you that when one doesn't work, you generally want to use another one. Well, there is a trial coming with a new drug called pasnotinib, and we're in the process of opening that. I'm hoping we'll have that open by early next year. And that would be for patients who've had one treatment and the treatment worked or didn't work, but now it's the tumor's progressing. So this gives a second option of where we can go to. And then this other trial that we're actually hoping to have open, this is just only to our center. It's a smaller trial, but it's looking at everolimus in combination with radiation to the liver. So like I had mentioned, radiation doesn't really work very well for neuroendocrine tumors, but we've got approved by Health Canada a proposal to see if we can give radiation to the liver and have that radiation. Maybe it'll work better if we give the drug together. So that's another option. So these are some of the clinical trials that we're working on at Sunnybrook or in the process of opening. How about to improve symptoms? Pasriatide is that new drug that we're coming about. There's going to be a trial coming out. We're not sure if they're going to introduce that trial in Canada or not. If they do, it's something we definitely would consider participating in to bring that treatment for people. And then there's another trial that we're not participating in, but we've been able to send patients for. It's called Telestar, and it's on the verge of finishing. They've almost got all the patients. And it looks like a new oral agent, and it's only to improve symptoms. So these are people who continue to have flushing and diarrhea despite all the drugs that we give them, despite all the artriatide. It still makes their life unbearable. This is a new drug, like a rescue medication. And the company will actually help fly you to centers where the drug's open. I think Buffalo is probably the closest center to us that's running this trial. But the company is very supportive in getting us support, et cetera. And I have had one person go, and it's been quite useful. So they won't pay for everything, but they will actually even give you a travel allowance to travel. And if you have family in different centers or places and that have the trial open. So that is an option. And I think that's a great way of approaching when we're dealing with a cancer where there's not a lot of people in one place. This is a great way of getting this research done, is by helping people, go to the places where they can get the treatment they need if we can't provide it here. We try to do what we can here, but if we can't, then at least get them a way to get to the place they need to be. I talked to you about, we try these drugs, but we don't know who's going to work in which one. We don't have great biomarkers. So in combination with our partners down at Princess Margaret, we just got a grant, I think you're going to hear about this, called the NET-SEQ. And I think, a lot of patients at Sunnybrook have gone down for this. And this is trying to look at patients who had a pancreatic neuroendocrine tumor, trying to look at, genes and trying to understand who responds to which drug and why. And so hopefully this will lead us down a pathway in the future of where we can understand, if there's any tests that can be done to help predict before we start the treatment about which is the right treatment for the right person. And this is what you hear about personalized medicine. This is sort of the cutting edge of that. So, we've been already doing this, and we've got a grant to expand this now. So we're going to be moving forward on that. Variability of Ki-67 looks at, it's a study we have that we've sort of published on, taking a look at all the previous patients that we've had to see, does that Ki-67 change, and how do we use that data to make sure that the people get the right treatments? And then Dr. Law and myself, both our training is in what's called health services research, which means we look at sort of big populations and try to understand what the trends are in the population and how does that tell us information. We just recently published a trial, or a study, I should say, on epidemiology and survival in Ontario. What we did find is in the last 15 years, the rate of neuroendocrine cancers in Ontario has more than doubled. And that means that, when people say, well, this is a totally rare disease, and it's not actually. It's much higher, and if we look at the numbers, we actually find the PNETs have gone up almost 6 times in that same 15-year period. And that's not a case of I think it's more common, which it might be, but it's definitely a case where we're detecting it better, we're understanding it better, but it's not as uncommon. You're not as alone as you think you are. There's actually a lot more patients with the disease than not. And that was looking at 6,000 patients in Ontario who've had new neuroendocrine cancers since 1994. That's from 1994 to 2009, and there's 6,000 patients. We have a number of other things, looking at virality, looking at access to care, how we're doing that, looking at patterns of care and costing in terms of understanding what treatments are, what are the costs of those treatments, and how can we best understand who's going to need what treatment and where, and then the guidelines that we talked about. So I think it's from a neuroendocrine site, but I wasn't quite sure. I don't know who else would want to be a zebra, but I think that, there are a lot of options, and there are a lot of things that are happening. Neuroendocrine treatment can be a complicated disease to try to navigate through, but I definitely think that as you move forward, you'll see that options are opening. This is there's been a lot of change in the last 5 years. This is definitely one of the tumors where we've seen the most change, and where we're actually able to making more and more of a difference. So I hope you come away from this understanding that not all neuroendocrine tumors are the same, but our options are improving, and it's just a case of finding the right options for the right people. Thanks.
So we're running quite a bit over, and I think the people who were online had a problem with sound, and they couldn't hear a lot of the presentation this morning. So hopefully that's fixed now, and I apologize to those of you online. I hope you can hear us now. Louise Binder is our next presenter, and Louise is going to have to give us an express version of her presentation because we are running quite a bit over. So as a lot of you probably know, Louise is the project manager for CNETS Canada, but there's so much more to Louise than just her role with us. She's a labor lawyer and co-founder of and past chair of the Canadian Treatment Action Council, where she spent the past 20 years in the health field advising patients and patient organizations provincially, nationally, and internationally on issues of health policy, and particularly treatment access issues. Louise has been recognized for her work with an honorary doctorate of laws from her alma mater, Queen's Law School, and by the province of Ontario with the Order of Ontario, and by the Queen with 2 Queen's Jubilee medals. In October 2013, Louise began consulting with us at CNETS Canada, and she is our project manager for the organization. She oversees a number of programs for us, our patient and medical education programs. She obviously organized this event here today, so a huge thanks goes out to her for that. And wouldn't be able to do it without her. And she's obviously working with us on our health policy work, fundraising, and so much more. I've come to know Louise as a dedicated and passionate member of our extended community. She does more than just work for CNETS Canada. She gives us her all, and she's helping us move some mountains, or at least try to move them, on behalf of all the patients. So, Louise Binder.
Thank you. I'm delighted to see so many faces that I know, and I hope by the end of this presentation, I'll know more of you. Before I start, I think we really have to recognize Jackie Herman. She has taken this organization so far while having a full-time job that's completely got nothing to do with CNETS Canada, that it's amazing. And she was the highest fundraiser in the recent Scotiabank Marathon for CNETS. And, really, she's just amazing, and she really deserves a round of applause. So what I'm going to do is explain to you how it's great. Dr. Singh talked about all these great trials that we're getting, and the chance for new drugs and so on. That's all terrific if we can get them approved for sale in our country, and if we can get our provinces to reimburse them. And otherwise, they're just gonna, as I always say, they'll just be in a museum somewhere that nobody ever got to use. And so one of the pieces of work that I work on is to make sure that as the researchers find wonderful things for all of you to stay alive and well, that we make sure governments allow them into this country and pay for them. And I want to talk to you a little bit about that, because really we always need your support when we're making those arguments to governments. And that's how Jackie and I first met, actually. One of the 2 drugs that's been mentioned here today was not being paid for by the Ontario government. And Jackie and I, our first mission together was to go to the drug programs branch in the province of Ontario and say, why are you not reimbursing this drug? And we were successful, and I guess that's probably when Jackie decided maybe we could do a few more fun things together. And I do think it's fun. It's fun to help people all the time. So my talk says why you can't usually always get what you want, and I hope that we're going to change that paradigm as more people are educated about this problem, and I hope the Rolling Stones don't mind the slight change in the language of their song, but that's unfortunately what does happen a lot. So here's, and we're going to work together for a minute, so you have to really listen up because I'm going to ask you some questions. So here's just a case study. So you've got a patient been diagnosed with PNET, and goes into the doctor and says, is there a treatment I can take? The doctor replies, yes and no. Patient says, what do you mean, with surprise? I thought all drugs were available once they made it through clinical trials. The doctor shakes his or her head side to side with a sigh. Not at all. Fortunately, a few of your disease drugs have made it through the complex and lengthy approval system. And the patient says, what holds up access to available drugs across Canada? And now I'm going to tell you. Okay, so I want you to listen to this list, and I want you to raise your hand when you think one of these is a possibility for the reason a drug isn't made available. Number one, the manufacturer of the drug hasn't applied to Health Canada to sell it in Canada. Is that possible? Absolutely possible, and it happens. Do you know that we are only 2% of the world market for drugs? 2%. So we've got to fight really hard to get clinical trials here because that helps get drugs into the country, and we've got to fight really hard to convince manufacturers that they should be adding us to their market. Is it possible that it's because Health Canada hasn't approved it as a safe and efficacious drug for Canadians? Is that possible? Oh yeah, oh yeah, absolutely. And even if we get through those two hurdles, is it possible that the health technology assessment process has not found it to be of sufficient, quote, value to recommend reimbursement to the provinces and territories on public drug plans? Is that possible? Absolutely it is. And even if we get through that hurdle, is it possible that the provinces may not have negotiated a price with the manufacturer that they find acceptable? Anybody think that's possible? Absolutely. And even if that's happened, you may be in a situation where, is it possible that even though they've negotiated a price, that one of the provinces, including Ontario, decides, I'm really sorry, we just can't afford it. We don't have enough money in our drug budget for this particular drug. And so even though we negotiated a price, we're not going to pay for it. Is that possible? Absolutely. All of these things are possible, and they all happen all the time. And of course, some people have private plans, so is it possible that your private insurer isn't covering it? Absolutely it is. And is it possible that you can't afford the Trillium copay for your drugs? Yes, I have friends who have actually had to stop taking medications because they couldn't afford the Trillium copay just to get the drugs, so I can answer that one. And of course, then there's any or all of the above, okay? That is what we have to go through just to get a pill into your hands. And that's unbelievable. And that's what I spend a lot of my time working on, trying to improve these systems, fighting with governments about them, and helping you do that. So there's a joke about why decisions that are made by committee are like a camel. And I say, why is Canada's drug approval and reimbursement process like a camel? And the answer is because it's a horse built by several committees over many years and by different governments. So when you look at a camel, it's got humps, it's got a skinny tail. Like, what is this thing? Look, have funny legs. Shouldn't even be walking around, right? And that's really the kind of system that we have. It's really just been added onto and bandaged up, and it really, if I had my way, of course, we'd all just have universal drug coverage for everybody, and then we would stop having to worry about all this madness. And before I have written a paper, by the way, with a formula for that, and I'm hoping to stay alive long enough to see that in play, and I hope that you'll all be there when it happens. So we know that Health Canada, its role is to decide if the evidence is good enough, that it's safe for you to take this drug and that it's effective. Let's not ever kid ourselves. There is absolutely no drug in the world that is safe and effective for everyone. Okay? Not a single one. You might have something that you personally creates a problem for you personally with that drug. So don't think that just because it's been approved, that necessarily means that it's going to be safe for you personally. And we've seen so many of these stories in the newspaper. Somebody died of this, somebody died of that. And, you know, poor Health Canada, frankly, I have some sympathy for them. They get blamed, and sometimes it's because the person took the drug in the wrong way. They shouldn't have taken it for what they took it for, or they had something genetically that made them react badly to that drug. So don't be fooled. But it is very important that Health Canada does review and make a decision about the drugs. We, as Canadians, are not supposed to have any role in that. Okay, they're supposed to do this behind closed doors and transparent and opaquely. But I want you to know that I know the folks at Health Canada very, very well. I've worked with them for nearly 20 years. And informally, we can go and have chats with them and tell them what we think about the drugs. And they're actually starting to develop a program where they're going to formally invite patients in at that level. And so we do have a role, and we've got to keep on top of Health Canada, and they know I do. This crazy health technology stuff, like, is this drug valuable? Well, by whose decision? Its value, and they talk about it in terms of it being valuable to the public and the healthcare system. How about the patients? It's valuable to the patients. So it's very important. Luckily, there is a system where we as an organization can put in an application and we really need you. You know, the drugs that Dr. Singh says are coming down the pipe, well, they'll go through this system. And we'll be writing out to you and saying, tell those of you who've had access to this drug or really need access to this drug, and we'll need your stories, because then we put those together and we submit them to these health technology people, and we say, take our patients into account in deciding value, because we are taxpayers, we are the public, we aren't some separate group of people. So it's very important that we have your support on these kinds of things to get these drugs through. And my warning to you is that recently the oncology review system is being rolled into another larger review system that does not take patients into account anywhere near as much as the oncology group has. I'm spending a lot of time watching that and writing to ministers of health and deputy ministers of health and visiting them about that. And we've got to keep on top of that. And I promise you that CNETS Canada is doing that. And when we see things that we don't like, we're going to say so very loud, very clear. So, as I say, we need your help in the submissions. Then there's something, something after that called the Pan-Canadian Pharmaceutical Alliance. What that is all the provinces got together and figured if they negotiated one price with the drug companies, they'd get a better deal. In principle, it's a great thing. it's a great thing. I'm totally supportive. It's got two problems, and I'm been working with the governments to talk about how do we deal with this, and many other cancer groups have as well. One is that while those negotiations are going on, no patients can get access to the drugs unless there's a special program that the company decides to put in place. And the other problem is the one I mentioned before, that they can actually negotiate a price, and then a province, and we've seen this with CNETS drugs, particularly in the Atlantic, even after all of that's done, they don't put it, they say we still can't afford it, even at the price we sat at the table and negotiated, and people still don't get access. So there's still lots of work to be done with this, and we're very actively involved. The good news is they've decided that Ontario is going to be the office for this. So since we're in Ontario and it's going to be in Toronto, and the assistant deputy minister is, fairly accessible, if things are really going badly, I don't have to travel too far to go and explain how to fix it. So how to get what you need, at least sometimes. Your role is to support the advocacy work that we do in this area. It's very important that they know that we're speaking for you when we go in and say, our people at CNETS Canada, people who are involved, want this drug. It's not just Louise wants this drug. It's not just Jackie who wants this drug. All our community wants these drugs. And so we really need to get some formal metrics around how long these Pan-Canadian Alliance negotiations are going to take, because it's taking too long for people to get things. So advocacy, I'm not going to go into this part because we don't have time, but the main thing I want to say about advocacy in this country is it's the squeaky wheel syndrome. I'm sorry to report. Systems should tell you what you're entitled to, and the bureaucrats should be there to help you. You don't ask the right question, you will not find out. So as much as they complain about people like me, oh, Louise, you're so noisy, and you're always knocking on our doors and sending us letters, if you don't squeak really loud, you will not get what you need out of the system. So keep squeaking, and keep squeaking very loud. And the other important thing to remember is, as an advocate, my role is not to decide what you want, or not to ask for things that you don't want. It's to do what you ask me to do. I'm your conduit to the system. So please feel free to write, phone me, talk to me anytime you want, and tell me the stuff you'd like me to be doing for you, because that's really what my job is. So I'm sorry to have kept you late. I hope it wasn't too long. And I have to tell you that I'm just about, October 1st was my first anniversary with CNETS, which Jackie didn't even remember, by the way. She thinks I've just been around forever. She's so used to me, she just thinks I've been around forever. But I have to tell you that it has been so much fun, and it is such a great community, and I'm not just saying that because you're here. I'm saying that because it truly is, and I enjoy every single moment that I spend working with you folks and just spending time with you folks. So thank you for letting me be a kind of surrogate member of this community. It's a real honor and a real pleasure.
Thank you, Louise. And it is an absolute pleasure to have you working with us. You know that already. She does an amazing job. Okay, so now we are going to break for lunch. It's 12 o'clock, and we'll have a 45-minute break. And so for those of you online, you'll probably see an on lunch or some kind of a message on your screen, and we will try to be back promptly at 12:45. So hopefully everyone will enjoy lunch, and we'll see you in about 45 minutes. So we're going to move on with our next speaker, Dr. Karash Kalali. He is an associate professor of radiology at the University of Toronto and an abdominal radiologist at the JDMI. Dr. Kalali completed his medical school at the University of Ottawa and moved to Toronto for his residency. He's been working at the University Health Network Princess Margaret Hospital since July of 2000, after completing his fellowship in abdominal imaging at the University of Toronto. His clinical and research interests have been in the field of hepatobiliary and pancreas imaging. He was the director of the Toronto Hepatocellular Carcinoma Surveillance Program at the UHN and the imaging lead for hepatobiliary pancreas imaging since 2006. Karash also has an interest in international health and is the co-director of medical imaging of the University of Toronto Collaborative in Ethiopia called TAAAC. Through TAAAC, Karash has been involved in creating fellowship programs in medical imaging at Addis Ababa University. Dr. Karash.
Here's going forward. Okay. Going forward this way. Okay. Thank you. Good afternoon. It's a pleasure for me to be here. And I hope that you will remain a little bit awake after having that wonderful lunch. I just had a bit of it, and I wished I had more. This is a very well-educated audience. I came in a little bit earlier and listened to a couple of the talks, and of course I was impressed with the speakers, but then I listened to your questions, and I was a little bit shocked and afraid now to face you because...
Okay, we don't fight.
Great, thank you. And I'm also very happy that Dr. Izzat is here because when I have any questions with regards to neuroendocrine tumors and something that I don't understand, I ask him, and I'm sure that if you're going to ask me questions that I don't know the answers to, and hopefully he can help assist, get the answers out to you. So I'm going to be talking about common imaging modalities, CT, MRI, and CT PET, CT SPECT scans. And then I will talk about neuroendocrine tumors. And because I'm a abdominal radiologist, I'm going to mostly kind of talk about the abdominal types of neuroendocrine tumor. But we'll also talk about how we make diagnoses and follow up. So CT scan, CT stands for computed tomography, and at some point it was called computed axial tomography in CAT scans, which everybody loved and made jokes about, but the A has been taken away. So CT scans were invented in 1971 by really a brilliant engineer named Hounsfield. And the mathematics for CTs, how to take those signals and turn them into images was worked out by a South African named Cormack, who used to work and study in the United States. So Hounsfield and Cormack received the Nobel Prize for creating CT scans in 1979. So from something experimental with the first patient, this is the image of the first patient, you can see in the right aspect of the screen. The first patient underwent this scan had a tumor, they thought, in her head, and it turned out that it was just a cyst. It was causing some symptoms, so the surgeon opened up the skull and took out the cyst or drained it, and was noted to remark that it looked exactly like the CT scan images. So at that time, it was just an incredible feat to be able to see inside the skull. Ultrasound scanners were rudimentary, but were present, so axial imaging or imaging through the body rather than planar imaging like chest x-rays and whatnot had been created, but it was the skull was the last frontier, the head was the last frontier because of the bony skull. So CT scans use x-rays to penetrate the body, and that's the way we can make diagnosis using CT. So it's a type of radiation, it's a type of ionizing radiation, but it's relatively weak as radiation goes. And by the way, light is radiation as well, so we're exposed to radiation, but X-rays are much more powerful than light. So how does the CT scan work? Well, CT scans have, is this a pointer? No, it's, oh, maybe I can use this. Perfect, lovely. So this is the patient on a table. So basically there is a source of X-rays, and that's the X-ray tube. There's a current that generated through this tube. And X-rays are produced by this and come out, and they're collimated in a fan. So the kind of a little slit-like area where this kind of light, which is made of X-rays, comes out and penetrates the patient, and then there's a detector behind it. And to be able to figure out where everything is, this source and these detectors have to rotate around and take pictures right around the body. And so in the old days, this used to go around once, and an image of the patient was obtained, and then the table would move ahead, and this would go around one more time, and then another image would obtain and whatnot. And at some point, somewhere in the 90s, technology came about. Thank you very much. Thanks very much, Dr. Azat. Technology came about where the ring could to go right around as the patient moved, and those were called helical scanners. So basically, if you hear the term helical CT, I would like a helical CT. That all of the CT scanners that are available now, they're all helical, so you don't have to worry about getting an older generation or not. And the latest thing that's happened with CT scans is that these the row of detectors that was just a single row, they become wider and wider, so larger areas of the body can be imaged at the same time, and so that's called multi-detector or multi-row CT scanner. You might hear, MDCT or terminology like that. So basically, this is inside a CT scanner where you can have all this apparatus, and that rotates around. It rotates around nowadays around twice a second or 3 times a second. So this heavy thing is going around. When I ask patients if they've had a CT scan, sometimes they're not quite sure what test they've had as a CT MR. So the CT I describe as the big donut. Have you gone through the big donut? And usually, and patients kind of realize that. And the way we differentiate this from nuclear medicine, where, for example, a PET scan, you would go through a donut as well, is that usually you're hooked up to a contrast pump. And intravenous contrast is injected through your body. So why do we need contrast? So here's an image that we get on a CT scan. This is an axial image. This is through the abdomen, my favorite organ, the liver. And so here we can see the liver, there is the stomach here, there is the spleen. But really, we don't see much inside them. We can see the liver as a blob, and there are blood vessels that are going through, and there are blood vessels going through the spleen, and there are other entities. There can be masses and whatnot, but we can't really differentiate that based on using X-rays. So what we have to do is we have to create contrast between the tissues. And one of the things we do is we ask you to drink some high-density fluid. And so that's called oral contrast. Sometimes we can give you low-density fluid, like milk would have fat in it, and that would be a low-density fluid. Or water, for example. You can see there is water inside the stomach. So because of the water here, we can differentiate the wall of the stomach from the contents inside. Another way to give contrast is to inject it inside the veins. And usually the contrast has the intravenous contrast, and sometimes we'll refer to that as the X-ray dye. So the intravenous contrast usually has iodine, which is a large atom and can stop X-rays. So this stuff is thick, syrupy stuff, and we have to get it inside you relatively quickly because it gets dispersed, and your kidneys are very efficient in getting rid of it. So you get hooked up to a pump that pumps this fluid, about 300 cc's, or like a beer can or a Coke can worth of this stuff, gets injected into 300 cc would be pretty maximum. It would be about 100 cc, so a third of a Coke can. Gets injected through very quickly, and then after that, we wash it down with some saline. And that gets pumped through you. And so the difference is when I press the button here, you should see what happens with the organs when we inject contrast. So suddenly you start seeing all sorts of things inside the organ that we weren't able to see. For example, here in the stomach, now we can see this inner lining that's enhancing. That means that it's got contrast going through it, and more than the wall, and that's the mucosal lining, the inner lining of the stomach, for example. Or now we can see the blood vessels that are traveling through the liver. This is the portal vein, for example. Or here's the aorta carrying this contrast that we got going in through. And the current generations of CT scanners allow us to have very nice thin axial images that actually go through the body. And so we can have very thin slices, and we can create them in any orientation. They don't have to be exact ways. So this would be an axial, this would be in coronal, like so. This is, but we can kind of create it in any different angle nowadays. And both of these scans are contrast injected, so you can see the heart is here and the blood vessels that are traveling to and away from the heart, and they all have the contrast inside it. So that's why it's so important to have contrast. You might have questions about, do I really need this dive? And you go for a CT scan. It does help a lot in terms of making the diagnosis. It does have its own issues because occasionally can affect your kidney function, and or if your kidneys are not working well, then will hang around your body a bit longer. We have to make sure that it leaves your body. So we do ask about how your kidneys are functioning for the CT contrast agent. For MRI, it's less of a concern, but it's still a bit of a concern as well. So this is intravenous contrast. So magnetic resonance imaging, or MRI. So this is a little bit harder to explain to you what it is, and it's very easy. If my explanation you can understand, it's because I understand it, and if my explanation didn't make sense to you, it's because it's harder for me to understand it as well. So MRIs are actually harder to understand than CT scans to a certain degree, and so there is this perception that MRIs are magical tools out there. Within the people who do radiology, also they give more credence to what MRI said than, let's say, what the CT scan said. But that's not the truth. The truth of the matter is that they're both excellent modalities and they have their strengths and weaknesses. So MRI was invented by three people, Lauterbur and Mansfield, and these two people received the Nobel Prize. But the third guy was not a part of these teams, and he was a bit of a independent loner type. And these two were PhDs. This guy was an MD, so he never got the Nobel Prize, and he's very upset about that. Dr. Damadian is still alive, and he's still there is a society that promotes him getting a Nobel Prize still. So we're going to talk a little bit about Dr. Damadian because he actually patented the idea. He was a specialist in nuclear medicine resonance, nuclear magnetic resonance, NMR, and he looked at some tumor tissues, and he realized that tumor tissues give a bit different signal than normal tissues. And so he wrote a paper in journal Science. He was a good scientist, no doubt, and he was a bit of a businessman too. So right away he ran and he decided to patent his idea. And for his patent, he drew this diagram where you kind of have this magnet, and this, the patient can move around, and they have apparatus, and you get signals from the patient, and and then he followed through with that. This would have been 1972 when he submitted this. 74, it got accepted as a patent, and he went around and he decided to build his own MRI. He actually jerry-rigged the very first MR scanner was built by him, 1979. But he never got the Nobel Prize. Anyways, so how does a magnetic resonance imaging MRI work? Well, so what it does is that it uses the intrinsic magnetic properties of the atoms in your body, and specifically the protons. So what it is a huge magnet. We're going to go to the next slide. So it's a huge magnet So it's a bit of a tunnel. You go inside a tunnel, and it's a noisy tunnel. So this is, people who've had MRI, you say you go in a noisy tunnel, everybody knows, yes, I've had that test. So, so you go inside this tunnel, and what happens instantly is that the atoms in your body, they kind of orient in the direction of the magnetic field inside this magnet, and the direction of the magnetic field is kind of in this direction. And then what happens is that we create radio waves. So here, this is a patient inside the tunnel, and these little red dots are their atoms inside their body. So they kind of get oriented in a specific way. And what we do is we use these coils, we send in radio waves. And this radio waves, as they interact with the atoms and these magnetized atoms, and they kind of excite them. And then when the signal stops, then these atoms will slowly relax, and that's called the relaxation time. And so when the atoms relax, then we can hear a signal back. And so we have send signals and receive signals, send coils and receive coils. So we have this receive coil, and then we kind of listen to the body and figure out, and how things relax will tell us what kind of tissue there is in each part of the body, or in each slice where we're looking. And so we do that same process kind of slice by slice, or different areas. There are many different ways of doing it. And then all the information goes into a computer, and at the end of it, I get an image. These images also can be in different planes. So here's a beating heart, and so you can see it's pretty amazing. You can see that you can actually visualize the flow inside the heart, and so you can see that there is flow in this direction from the atrium into the ventricle, but also there is abnormal flow. The heart valves are not working properly, and there's abnormal flow going back as well. So there is, when the heart beats this way, it goes in, and then when the ventricle contracts, the blood goes back into the atrium. And also you're in this big tunnel, and so we have the ability to image a good proportion of the body. So we can do whole body MRIs, or large segments of the body as well, and you can get these beautiful images that are very pleasing anatomically. But despite the fact that MRI gives you a lot of contrast between the different tissues, you still want to see how blood flows into things. And the best way to do that still is by using intravenous contrast. So we have a different kind of intravenous contrast for MRI than we do for CT scan. And that's called gadolinium. Usually it's the most common thing would be an agent that contains gadolinium. And so in this case, we've injected into the veins, and this is as it travels through the heart and the lungs, and now comes down and goes into the organs, into the body. And so this is dynamic injection of the contrast as it disperses through the body. So the other thing about the MRI, and also for the CT scan, is that a lot of times when we're trying to take these pictures, these take time to acquire. And so if you're moving, you're breathing, we have to do something to compensate for that motion. Because if you're trying to take something, just like you're trying to take pictures of your kids and they're moving around, right? So one way is to say, stop moving. And so, the machine will, the technologist will ask you, or the machine will ask you, can you take a breath and hold it? Or there are other ways, depending on what we're trying to do, to compensate for that motion. So, for example, I'm an abdominal imager. We look at the bowel moves in all different ways. So you might receive a medication that slows down the bowel for about, half an hour to an hour, so we can get better images of the bowel itself. So PET scans and SPECT scans have been around also for 30, 40 years. But they, although there was a lot of literature for them, they really started to take off and become very useful when people started to use them in combination with CT, and now more recently with MR. So you might hear a PET scan, or you might hear CT PET. But chances are you're going to get a CT PET. If you're just getting a PET scan without the CT component, you get less information from the scan itself. So this is a PET machine. This is a CT PET machine. Okay, so inside the donut has the ability to take both CT images, like I showed you, and also do PET. And this is a CT SPECT machine. So these are the SPECT cameras. Then they will go around you. It takes time for these to acquire a signal from you. So you're lying there for half an hour, 10 minutes sometimes, and these will kind of go around you and take pictures from different angles, and then you go inside the PET and the CT component, and you'll have the CT information. So how do they work? So with nuclear medicine, either you inject a radioactive element that itself is metabolized by the body. For example, iodine is an element that our body uses. The thyroid will pick it up, and so if we give a radioactive iodine, then it goes into the organs that pick the iodine up, including the thyroid gland. Or we hook up a radioactive element to a molecule that binds a specific receptor. For example, somatostatin is a hormone. Somatostatin receptors are not uncommon, as you know, in neuroendocrine tumors. And so if we hook up somatostatin somatostatin analogs, like octreotide, to a radioactive element, like indium or gallium, then you can do SPECT scans or PET scans using somatostatin analogs. And the commonest things that we're using now currently are somatostatin analogs like octreotide, or adrenaline analogs, or catecholamine analogs, another term that's used. And this would be MIBG. So MIBG stands for methyliodobenzyl-guanidine. And I can only tell you what it stands for when I have it written out in front of me. But most people know what MIBG is, but most don't know what that is, including me. Anyways, so this is a catecholamine analog, and so for tumors that secrete, metabolize or secrete catecholamines, then we can use MIBG to visualize them. So in this case, instead of the radiation being directed or shone onto you, the radiation is injected inside you, and you're the source of radiation. So the radiation comes from the inside you, and so what goes around you is just a camera trying to catch the signal that comes out of your body. So one thing about nuclear medicine is that the bathrooms around the nuclear medicine department are usually quite radioactive, right? So unless you've been injected yourself, you usually avoid the bathrooms around nuclear medicine departments, because you're the source of radiation when you have the stuff injected inside you. So here's an example of what PET is. So a PET scanner basically has sensors that are a ring of sensors right around you. Okay, and so for PET, it's positron emission tomography. That's what it stands for. And SPECT, single photon emission computed tomography. So positron emission tomography, basically it means that we're using positrons to get axial images of your body. The positrons are actually not what causes the image. These are radioactive elements that produce positrons, and positrons are just the opposite of electrons. So an electron and electrons are all around us. When a positron is produced by one of these radioactive elements, it instantly hooks up to an electron. It becomes very happy, and two babies are produced at the very same time, and these babies are X-rays. Two X-rays are produced. These X-rays, though, because they're produced by elements, they're called gamma rays. So you might hear the term gamma rays. Gamma rays and X-rays are identical. They're exactly the same thing, same energy range and whatnot. So these gamma rays, when these positron and electron hook up together, they are produced and they go in exact opposite directions. And that actually helps, the fact that this process will produce two at the same time helps PET scan become a better imaging modality, because what you have is you have a coincidence detector where it detects only signal that's produced at two areas at the two different detectors at the same time, or two opposite detectors at the same time. So if it only gets signal from one area, then, or from one gamma ray, then it won't register it. But when it gets it exactly at the same time from two different opposite directors and said, this is a signal that's coming from the body. And based on the signal that is getting from the different rings, it can figure out exactly which part of the body, well, not exactly, but about which part of the body it's coming from. So PET images and SPECT images are never as clear as CT or MR because the radiation is distributed throughout your body. It's not one area where we're kind of shining through, and coming out of your body. It's coming all over the place, and so the images are not as crisp. It won't form as crisp or clear, and that's why it's used in combination with CT or MRI. Good. Now we're going to move on to imaging of neuro. Was that clear? Great. Good. Those of you who think you totally have understood it, maybe afterwards can explain to me, so I can become clear too. So now we're going to talk about neuroendocrine tumors and imaging of neuroendocrine. Exciting things that are happening with neuroendocrine tumors are probably on the nuclear medicine front. So you hear about lots of things. The mainstay of nuclear medicine is CT, and I'm just kind of standing behind or trying to move away from the microphone because I'm getting the feedback. But if you have trouble hearing me, just kind of wave to me and I'll talk louder. So CT and MR are still by far the mainstay of imaging that we use. And why? Because they're so crisp and clear in terms of looking at anatomically where things are within the body. So we use CT and MR for anatomic localization. This tumor, somebody will have an abnormality. The blood test is done, and they figure out, there is very likely a tumor that's producing this hormone abnormally. So where is this tumor? So one of the things we can do is CT or MR to figure out where it is, which organ, but not only just which organ, exactly where it is within that organ, what is it touching, how many of them there are, where has it spread. We also use molecular imaging quite a bit, and molecular imaging, because it's very specific to the receptor analog that you're attaching your radiation or your radio to. It's much more specific. So you're going for a specific receptor, for example, and so if there is a tumor that has a concentration of that receptor, then you can say, this tumor is this kind of a tumor. So this mass is this kind of a mass, and so it has the specificity that CT or MR may not have. But it's not as clear, the images are not clear. So for anatomic localization, we still use CT and MR quite a bit. And also CT and MR tend to be a lot more accessible, easy to access, especially CT, not MR. And so it's a lot easier and cheaper to follow you using the anatomic modalities. So one of the things about neuroendocrine tumors is that they generally, although not all of them, generally they tend to be quite vascular. And that means they have more arteries and more blood vessels inside them than the tissue from which they arise or the tissue in which they are located. And that means that when we give that X-ray dye or the MR contrast, and it's going through your blood vessels and we take these images quickly, that tissue will stand for that adjacent organ. And so here we have a liver. Now this is kind of taken in the coronal plane like so, and we're cutting through the liver, and there is the heart sitting, and these are the lungs up here. These black holes are the lung on that side and that side, and we have the liver, and there's the gallbladder, and this dye, and now you can see the blood vessels inside the liver are now visible, and there is the pancreas is lighting up, but there is a mass inside the pancreas that's lighting up more than the adjacent tissue. And so we can say, this is a mass, it's a hypervascular mass within the pancreas, and hypervascular masses within the pancreas are primary neuroendocrine of the pancreas. And so now, sometimes we can see these really nicely when the arteries are really filled nicely with contrast, and sometimes we can see these nicely when the veins are filled with contrast. And so we don't know which is which, and so you'll have multiphasic scans. When you have a CT or MR, they'll say take a breath and hold it. They'll take it, pump is injecting dye inside you, then and then it says take a breath, hold it again, and you might for an MR do it 3 or 4 times. For a CT scan, likely twice. You'll hold your breath, and the pictures are taken in what we call different phases as this dye is flowing from the arteries into the veins and through the organs. Try to best bring out the mass and the other organs as well. So this is a multiphasic CT scan of the abdomen, and we can see a mass inside the pancreas. That's a neuroendocrine tumor inside the pancreas. So some of the common neuroendocrine tumors of the pancreas, so catecholamine secreting tumors, and these would be pheochromocytomas, which are really a type of paraganglioma. So there are paragangliomas inside the adrenal glands, pheochromocytomas, paragangliomas, and neuroblastomas. So how do we image them? Well, we image CT and MR still for localization. So is there a tumor and where is it? What is it touching? Can it come out? Like that. And another one that we use is MIBG scan, and we look for function and for follow-up. So this mass that we're seeing now, is it a neuroendocrine tumor? And so we do an MIBG scan. We look for other ones to present. So here's a case presentation. So this is a young woman that was undergoing surgery for some other reason. And after surgery, immediately after surgery, she started having very high blood pressure, severely high blood pressure, high enough that the heart had trouble functioning. And the heart started failing. And so the clinicians got very alerted and tried to figure out why is it that the patient has such high blood pressure. And one of the things is to look for tumors that produce adrenaline or catecholamine. And so they asked us to image the abdomen to see if we can find a problem in the adrenal glands. And yes, we found on this ultrasound, I'm not even going to explain ultrasound to you. It's fuzzier than the other ones. So we did find a large-sized mass. This is the kidney, right? Large-sized mass on the adrenal gland. So we suspect that the patient had a pheochromocytoma. That was confirmed by blood tests as well. A couple of days later, this tumor, which not uncommonly can do, is started to bleed. And so the patient had hemorrhage from the pheochromocytoma. So this was the tumor originally we saw in the ultrasound, and then this is all the bleeding that's come out, and it's around the kidney and whatnot. And we can actually see that at the time we were doing this imaging, some of that X-ray dye has leaked out of the tumor into the blood clot. So at the time we were taking the image, there was actual active bleeding as well. And so then we did a MIBG scan to see if there is a tumor just there or anywhere else. And so on the MIBG scan, you can see it's not as clear now. These are the 2 kidneys, and that's the tumor, the adrenal mass that we can see. So it's active. The rest of the area here, you might think this could be tumor, but this is the beauty of MIBG scan, nuclear medicine, is that none of this is picking up any or giving us any signal. So the tumor is just this. And so MIBG scans have this use where we can see not only at the site of tumor, but look elsewhere in the body for tissue that's secreting that type of hormone that we're looking for. And so in this case, there is also a mediastinal mass. And the images here, so this is a SPECT scan that has been overlapped with a CT scan. So this is the CT SPECT. And so we can see that there is activity in the chest as well as both adrenal glands as well. Pancreas, of course, has 2 functions. Digestion, so it produces digestive juices. Your pancreases are very busy right now, but also it produces hormones. And the hormones will be for sugar balance, insulin, also glucagon, sugar balance, gastrin for stomach production. All of these are happening right now in all of our stomachs. And because of all this hormone productive tissue, neuroendocrine or endocrine tissue, there are common sites of neuroendocrine tumors as well. And so we can see that neuroendocrine tumors are very vascular. In this patient, an axial image through their abdomen, we can see that there is not one dot that stands out in the pancreas. You have to take my word for it, there is a pancreas. But there is another dot here, and there's actually a bigger mass here. So this patient has multiple neuroendocrine tumors in the pancreas, and this is part of multiple endocrine neoplasia syndrome, MEN syndrome. So some of the other details that you can see with CT scans here, we can see that there are multiple bright masses. So these are metastases from the tumor. This is a big vein, but the rest of these are metastases. And then we're looking inside the liver, and so there is hyper-enhancing mass. So these are metastases within the liver as well. Not all of them will respond in this or behave in the same way, but most of them will. So pancreatic neuroendocrine tumors, insulinomas, and they can produce, so these are usually discovered quite early because they produce symptoms very quickly. Patients become hypoglycemic and have fainting, all sorts of issues. And so very quickly they're discovered by symptoms, and our job is to look for them. Sometimes we can see them on ultrasound, sometimes MR scans. They can be really tiny, so sometimes we have trouble seeing them, and we just have to go intraoperatively and look for by ultrasound intraoperatively to find them. Other tumors would be things like gastrinomas, and they can be, and when these can produce, then when there is a tumor like this, they produce, induce the stomach to produce a lot of acid. So there is a lot of ulcers, watery diarrhea, and so on a patient that has gastrinomas, we can see the stomach is full of secretions and thick folds, and then there's ulcers in unusual places where we tend not to get stomach ulcers. Like usually we get stomach or duodenal ulcers. These are parts of the duodenum that we tend not to get ulceration, and so endoscopy is done. You can see the wall of this bowel is quite thickened and abnormal as well. So gastrinomas are usually produced in the head of the pancreas and or in the duodenum, and so we can, when we find one, we look for other ones. And so there is one in the duodenum here, there's another one in the duodenum here, there's another larger one that's hanging off the pancreas, but is likely duodenal as well. Neuroendocrine tumors of the lung, a lot of times they're discovered because of symptomatology from what they're by their mass effect. Either they're blocking the airway, or incidentally they're found on a chest x-ray like this one was. And so we did a CT scan in this patient, and we found a tumor. This was biopsied, and it was a neuroendocrine type of tumor. But unfortunately this one was growing relatively fast, so by the time they ended up getting a PET scan, this is a CT PET, so this is a coronal image. So you can see this is the CT scan without the PET, where there is colors, that's the PET superimposed on the CT. So the PET will show you where there's activity, the CT will tell you which organ it is in, and so there is in the liver metastases as well as in the lung. Another common type of tumor would be in the abdomen, would be carcinoid tumors, and these are most commonly in the small bowel, the appendix, sometimes in the stomach. So this one is a neuroendocrine tumor of the stomach, so the lining and the wall of the stomach on the medial aspect, on the middle aspect of the kidney, stomach is thickened, and so endoscopy, you can see this big thick fold which got a tumor is. So what CT scan, we can see the outside of the mass. On the endoscopy, we can see the inner lining, the stomach, and what it looks like on the inside. In terms of the bone disease, neuroendocrine tumors generally cause dense bone formation. So the terms that people use are osteoblastic or sclerotic. So you might see in your report there is a comment on a sclerotic lesion in the bones. What we're worried about or looking for are bone-forming tumors. And neuroendocrine tumors tend to be bone-forming, so they tend to be sclerotic. And so this is the same patient over a year and a half. And so you can see this tiny little dot wasn't initially picked up at this size, of course, because there are all these tiny little dots inside our bones. But over time, you can see that this is a bone-forming tumor, sclerotic focus, that's growing over, I believe, a year and a half. So future directions, you were talking about gallium-68, and so you're all, or you are aware, some of you, that there are newer receptor analogs and better ways of imaging them. And so gallium-68 can be tagged onto somatostatin analog, and so we can do, instead of having a SPECT scan using indium, you can use gallium-68, and it tends to be much more sensitive than a SPECT scan in picking out where the tumors are. So that's the combination of CT with PET using gallium-68. So tagging of new analogs or newer radiopharmaceuticals can lead to focal therapy. So if you have high energy radionuclides, then these can go where the tumor is, and they can ablate the tumors without the needs for surgery, or when the tumor is not accessible for surgery. And of course, every about 7-8 years, there's a continuing improvement in CT and MR technology. So CT technology is about due for another generation of improvement, and as that happens, we tend to see finer things and better, faster. So that keeps my job interesting as well. I'm going to stop at this point. I believe I'm out of time. My pleasure.
We're going to ask that you hold all your questions until the end, and then we'll have the three doctors presenting this afternoon come answer your questions for you. And we apologize for the in and out of the sound here. There's not a whole lot we can do. There's apparently some issues here in the venue, so we're sorry about that. So our next speaker is Dr. Shireen Izzat. He is a professor of medicine and oncology and head of the Endocrine Oncology Site Group at PMH, part of UHN. Dr. Izzat obtained his medical degree from the University of Manitoba. He completed his residency training at the University of British Columbia and his postdoctoral research training in molecular oncology at Cedars-Sinai UCLA School of Medicine in Los Angeles. Dr. Izzat has co-authored and co-authored more than 250 original research articles and 40 invite review articles. He's delivered more than 150 invited lectures. He supervises undergraduate and medical and graduate students, as well as postdoctoral fellows. He teaches a number of courses, including physiology, biochemistry, developmental biology, and endocrinology. I'm not sure where he finds all the time to do all of this and treat us as patients as well, but one thing that I wanted to add to this is, first of all, Dr. Izzat has given so much of himself and his time to our patient community. He has assisted me time and time and time again in assisting some patients who have approached me for help, and I've turned to him many times, and every time he's come through for me and for the patients. So he's truly very passionate about his work in this area and with our patient community. So on that note, Dr. Shireen Izzat.
Very much, Jackie, for the kind words. I'm not sure if I can really live up to all this, so perhaps you should just speak to my children at home, and they'll tell you the real truth. So I really enjoyed Kuroshi, a fantastic job at pretty much explaining everything to you. So really my job is going to be more to actually expand more on what he has done so far, which has really been a brilliant job. Was the one who was behind this topic today, and some of you may ask, what is this paraganglioma pheochromocytoma doing here? So I'm going to first ask how many, by show of hands, have heard that term before, or know somebody who's had it. Okay, well that's good. So that gives me an opportunity to actually make impact, as they say. Hopefully I can tell you what my outline today is going to be on just exactly what these conditions really mean, why I'm talking about them, how they actually present, and how do they really differ from other sort of more classical neuroendocrine tumors, and more importantly, why does it matter? One of the things that you and unfortunately medical doctors don't quite really appreciate. Why does it really matter, and what are the implications not only to what I do believe very strongly about is the rest of the family, and you'll get how critical this is. So the fact of the matter is that there are some situations where these tumors will present with very specific symptoms, such as the one that Lily described, where the patient basically comes in with boring manifestations that are so obvious: headaches, sweating, palpitations, pallor. The patient basically forces doctors to actually listen. And happen to be in the doctor's office or in a hospital and they have heart failure, they have no choice but to actually listen to the patient and try and figure out what's going on. But the truth of the matter is that many of them are in fact very nonspecific. They will include things such as not feeling well, having headaches, having constipation, putting on weight, losing weight, so who doesn't have these? And then, they can also present when sometimes they go to see people like Dr. Law, where they have compressive features. They basically, in the chest or somewhere else, they'll present with something, mass effect, and go to Dr. Khalili, who does the scan, identifies the mass, and sometimes, sadly, what we really worry about is that people are tempted to just stick a needle into this mass. And that's called a biopsy. And really speaking, biopsy is a good thing, but not really. The last thing you want is to stick a needle into something such as a periganglioma or pheochromocytoma, because two things happen. One of them is that they can actually bleed, like one case that Dr. Khalili described, or the other is literally trigger an explosion inside, because then they're huge surge. I'm not sure if I actually really need the microphone, because if it's going to make static, I don't like it. Yeah, you need it for the online? Okay, sorry. But the other manifestation that I just want to explain here is that sometimes actually pheos and perigangliomas present as so-called unexpected finding, a finding that really nobody had predicted. So what the heck are they? So I want to first explain what the term paraganglioma means. So ganglion is a collection or a bundle of nerve fibers. Okay, this is the electrical system of a body now. And what you'll see in the picture here on the right is basically from the base of the neck right through the chest into the abdomen and all the way down into the bladder, we all have the fibers. We have to, because if we didn't, we wouldn't be able to coordinate everything from our eyes to our hearts to our lungs to our bowels to our bladder to everything else. So we need those bundles. When those bundles turn into a tumor, we call that a paraganglioma. Para meaning besides the ganglion. When the gland itself, chromosome, we talk about these are. So why do we call them neuroendocrine? The electrons that also respond and stimulate the hormone signal. So these are specific electric junctions that are closely tied to the hormone producing system, hence the term neuroendocrine. So now you know that we now have a close association between the cousins of neuroendocrine, and these specific tumors are neuroendocrine tumors. And you can see here's an example of a patient where they didn't have one, but you can see multiple paragangliomas. Okay, and because they arise typically, as I said, they can be several, and it can create a lot of havoc. And I will talk a little bit more. When they happen to be within the adrenal, you can also see these tumors that we call chromocytomas. A lot of, unfortunately, doctors don't quite really appreciate the difference. But you'll see in a minute that this difference is critical. But first, I just want to explain the nerve bundles and tumors arising from the nerve bundles that we call paragangliomas. Those that typically arise early in life, and early here, at the age of 50, are particularly problematic. Why? Because they indicate likely two things to have occurred. One is that they're heritable. That is either occurring early on in life or involves multiple sites within the body about hereditary. And that's different from the genetics we were talking about before. We were talking about the genetics of tumor that you send your tumor to in order to know what's going on within the genes of that particular tumor sample. Here we're talking about the genetics of the patient, meaning we're talking about the genetic makeup of that individual. So I can do that test on any cell of your body. In fact, you can do it through a blood test where we isolate white cells and we do analysis on it. But the important thing again here, remember, genetics of a heritable nature, meaning that it's passed on from one family member to the next. And indeed, there is very strong evidence now that for this type of tumor, that if it happens to occur and is identified in an individual under the age of 50, it is far more likely to be heritable, and it is also far more likely, unfortunately, to be malignant. So it is a big deal. It's a big deal because it's going to be of critical importance to this particular patient and to their family members. Okay? So for those who are asking why does it matter, it makes a big difference. And of course, the other possibility is that it tells us more about what we might expect down the road for that particular patient. Meaning, so that patient, for example, that Dr. Khalil was describing, if you take out that tumor and you give the patient the impression that that's the end of it, that's the be-all, end-all, and that patient turns out to have a periganglioma syndrome, you've done them a disfavor because you gave them the impression that this was a single event, when in fact it is not. It is probably one of many others. And indeed, he showed you also examples of such individuals where there are multiple tumors. It's relatively easy to understand when they all happen at the same time. But when the tumors occur separated by time, that's where things become a lot more complicated, and that's really where you need somebody who truly understands sort of the ins and outs of this particular disease. And that's also where we have to go to Dr. Khalili and ask him, okay, what are the chances that, A, we've missed something on that particular patient? So one thing that I always ask a radiologist is, okay, so this patient, do they have any that you can see? And you'll see in a minute what it is that I'm asking. So, this is a particular chromosome. This is supposed to show you. And on the left-hand side, I'm going to show you this complicated picture, which is about the chemicals. We all ingest amino acids in something that's called tyrosine, and we all, because this is an essential amino acid, the body actually converts this to make dopamine. And by the way, this has nothing to do with dope. This is a very different. This is a critical substance the body produces our blood pressure. In fact, if you go into septic shock and you end up in care unit and your fusions of this substance called dopamine. Okay? The body then converts this dopamine to something else called norepinephrine. And adrenaline and noradrenaline. So everybody knows that when you get really off, your adrenaline goes to the roof. Of your body, like your fist, for example, or your legs if you're being chased by a lion or something to that effect. Also occur in conjunction to the surgeons who are in the operating room because they're really scared knowing that there's something wrong with the patient. Their own blood pressure also goes up. stand a chance of not only heart, but also in your. So it does, and it is if this is identified beforehand, after the fact, and more importantly, if we're sticking that needle in, which can also cause a huge surge in. To also bring to your attention is that when you produces dopamine, we associate this with different. So the ones that produce predominantly dopamine, this cluster genes, and this is called SDA. To that a little bit later on, as compared to predominantly producing tumors. In other words, that there are different genes that predominantly will result in an excess of norepi or epi. We can go and not just get lost in the other family members. We same problem in your family. So we're being very targeted. I'm going to try another one. Okay, no problem. The second group, and this is the one that concerns me a great deal, and I don't know, again, how many of you in this room have heard of this term, VHL. Von Hippel-Lindau. VHL is actually very, very important, and it's important to appreciate because not only do you get paragangliomas, but it also causes other abnormalities throughout the body, including the back of the eyes, so patients can lose their sight. They get tumors of the blood vessels in the hind portion of the brain, and they get multiple tumors potentially over the back of the spine that can result in cord compression and paralysis. These are pretty serious things, and if that wasn't enough, they're also at increased risk of kidney cancer. So that this information now, you can imagine, transforms us from an entirely area of where we're looking at the patient now, but it gives us an opportunity to actually predict what this patient is going to be at risk of and manage them in a very focused, efficient, and expectant manner. This is very, very critical, and I can tell you I've worked very hard for a number of years now to finally have a VHL clinic at Toronto Western Hospital where we have a dedicated doctor who's an ophthalmologist who knows what eye problems occur in patients with VHL. Why? So they can be seen on a regular basis every single year and not have a patient go to any ophthalmologist and say, I think I may have VHL, or I've been told I have VHL, so please look in my eyes, and they look at you and say, what? That type of lack of expertise creates a huge problem as compared to having a very focused team of doctors who know exactly what the manifestations of this condition are and what it is that they need to do and what it is they need to do on not only immediate but on a surveillance plan so that they're not ordering all sorts of unnecessary tests, but more importantly that they are actually asking for the right test at the right time in a very responsible and focused manner. And then we're going to go down here to this group that predominantly produces mostly epinephrine, and this is a group that is related to what we call RET and NF1. So I'm going to spend a minute on these two for a second. NF1 is a relatively easy one. This is neurofibromatosis. Many of you probably have heard that term, neurofibromatosis. You may have even seen some patients. The extreme situation is where you get physical disfigurement. You actually get to be very disfigured because you get tumors over the skin, the nerve endings, you actually get multiple tumors, and these can be so incredibly disfiguring. They're all over the place. Sometimes they're hidden, though. And I saw just recently a patient a week ago, and she presented with a pancreatic tumor, and I was examining her, and then I noticed that she was sort of holding onto her arm very carefully, and I said, "Is there something wrong there?" And she said, "Well, I've had these bumps here that I've been seeing dermatologists for, and they really didn't quite make up what it was." Well, what she had was really neurofibromatosis, NF1, that had been unrecognized. And of course, we were able to go back and really identify that she also had an adrenal tumor in addition to a pancreatic tumor. And then we had to reorganize her entire treatment plan to really be able to appreciate what's the priorities, what the issues are, confirm genetic testing, and bring in the family members and so forth. So you can imagine that how important it is to be able to find these clues. And the sad part is that in many instances, the patients are not really aware of. So one of the things that I'm really trying very hard in my educational efforts with my residents and other doctors is they say, well, there's no family history. And I say, no family history that is known, no recognized family history. It doesn't mean that there is no family history of the same. It means, did you really ask what happened to the parents and the grandparents? What did they die of? What were their circumstances? What were the uncertainties around their illnesses? Now, that is not to in any way heighten or cause anxiety. On the contrary, I would argue when sometimes I'm criticized by other doctors and say, well, you're just simply making people more anxious. And I say, on the contrary, if you actually try to make a very specific and focused diagnosis, you have now allayed anxiety, because the most anxiety-provoking element is uncertainty. And that's what I'm talking about here, okay? So hopefully some people will begin to change their minds about this. Secondly is RET, and I want to emphasize RET. So RET, fortunately, is now covered by the provincial government in terms of testing. The term is rearranged in tumors of the endocrine system. But really what it means is that the patients are at increased risk of developing not only pheochromocytomas, but also they get tumors of the thyroid and the parathyroid. And the sad part is that these can be very malignant and can affect children at a very early stage in life, like even toddlers. So we can now identify this with high certainty that if a family is identified as having a RET mutation, we can know exactly what mutation it is, and we can go to the mother and within the first year of life take out that child's thyroid if we know that they're going to be at risk. In other words, we can do something prophylactically, actively about it. Okay? So there are already examples of this, and so for those who say, well, this really doesn't matter, you probably haven't looked hard enough, is my response to them. So, again, I think this slide may appear on the surface to be complicated, but really it is not. It just simply tells you that we have learned, and indeed, while this entity is considered to be relatively rare on its own, if you start to combine it, it's actually not that rare, and a lot of things are now in this big, huge puzzle are beginning to fall into place. And the Europeans have done a far better job than we have in North America in terms of collecting information on families, on their genes, on their natural history, so we know what to do with them at what stages, not to overtreat, but more importantly, to treat those who need the best therapy at the right time. And this is just simply a slide. I don't want you to obviously remember it, but just simply to, again, to appreciate that there are different genes. We now know from the Europeans predominantly what to look for in their blood and urine tests. And I want to emphasize there isn't single blood tests, because remember, just to remind you again, these elements here on the left-hand side are different chemicals, and each of them means something that's very, very different. So when people say, I've measured catecholamines, I say, which one? A lot of times they're thinking only about adrenaline. I say, well, what about dopamine? Have you ever measured dopamine? And they say, I have no idea why. So again, it's important to appreciate that there is a specific gene with a specific biochemical features that are identified in the blood and urine, and that these correlate with the clinical presentation in the patient now and later. Okay, So the next question, and I'm just going to show you some slides. These are now cuts that are even more magnified than Dr. Khalili's. He's shown you, what, maybe 10 times magnification. Here we're talking about somewhere around 2 to 500 magnification. So this is an example of what was diagnosed in one of my patients, and she was diagnosed as a neuroendocrine tumor. And it is a neuroendocrine tumor. These are endocrine cells, and we call them vascular, as he's pointed out. The reason why they're vascular is because they have to dump their contents into the bloodstream. That's their function. That's why they have to be vascular. And that's what the pathologists are really typically looking for, is what we call a salt and pepper. The salt and pepper appearance just basically means that these are cells that are grouped together and have the capacity to communicate with each other, to dump their contents into the bloodstream, and the salt and pepper inside of them are the peptides. But when they look at them, they say, okay, this is a neuroendocrine tumor. Okay, and it looks relatively benign. It looks fairly well differentiated. They all look very much the same. Next, neuroendocrine tumor. Patient gets it removed. It's gone, and that's the end of it. But of course, there's a lot more to it than that, because this particular patient came back 5 years later with a liver completely full of disease. This was the initial tumor, was removed from the lung. So we had to go back and identify the first tumor, and indeed, the initial tumor, when stained, it was chromogranin positive, and everybody knows chromogranin, and you measure chromogranin in the blood, and you measure it in the tissue, and it's elevated. The problem is that we found some other features in that particular tumor that, and I don't want to bore you with the details, but these are called transcription factors, basically proteins that determine specifically what hormone is going to be produced by that particular tumor. And essentially turned out that these transcription factors were negative. So that even though this tumor was making chromogranin, it wasn't producing the hallmarks of what we would expect from a pancreatic neuroendocrine tumor or a small bowel neuroendocrine tumor that you heard about earlier. So that led us to think, okay, so this is a neuroendocrine tumor that is negative for the usual features, and therefore the differential is, it could be a pulmonary neuroendocrine tumor or a paraganglioma. And with this, we have to go back and look at the substance that is required to manufacture dopamine, our good friends dope, noradrenaline and adrenaline, and that rate-limiting enzyme is called tyrosine hydroxylase. You don't have to remember the term so much, but TH, so this is the enzyme that actually takes the amino acid that we eat to make the substances I was telling you about. And you can now look for this tyrosine hydroxylase, because that tells you this is a tumor that has the capacity to manufacture these adrenaline-like substances. And that pretty much nails it. That tyrosine hydroxylase starts to now take you completely off in a very different direction and starts to tell you what the potential nature of this tumor is. It's actually very simple. It's very easy to apply. It doesn't take a lot of intelligence to really figure it out, but you have to think about it in the first place. That's really the key point. And, you know, the beauty of really many of the aspects of what we try to do is to identify the most fundamental basic principles, apply them in a very systematic way, and as you can see, there are payoffs for that. And indeed, this turned out to be a tumor that arose from the lungs, and when it was not a lung neuroendocrine tumor classical, this was a pulmonary paraganglioma. And had this been identified, I think this patient probably would have avoided a lot of other problems that came afterwards. This then allows us to be able to know which family of genes to look for and be able to do the appropriate tests. I won't bore you with the details, but there are now SDH, even within a class of so-called succinate dehydrogenase, or SDH, we now know that there are different family members, and some of them produce mainly pheochromocytomas, some paragangliomas. The one that I want to bring to your attention, though, is SDHB. This is the most plentiful paraganglioma syndrome type 4, or MEN4, if you will. This is very different from multiple endocrine neoplasia type 1. This is the one that we worry about the most because this is much more likely to be malignant. And we can actually measure it in the tissue so that, unlike normal tissue where SDHB is present, when you have this mutation, the SDH enzyme is actually lost due to this mutation. So again, very simple tests, not rocket science, doesn't cost $1 million, and you actually can apply it to the tissue. Now, the important thing though is, what if a patient had surgery many years ago? Can you archive this tissue? And what kind of condition has that tissue been stored in to be able to allow us to retrieve it in a manner that allows us to be able to apply these tests? And the good news is that with immunohistochemistry, there are now better techniques. So even if a tissue has been sitting around for 10, 15, 20 years, we can actually archive it and do some of these tests on it. So it still is within the realm of possibility. And indeed, we now insist on doing this test on a regular basis, especially when things don't quite fit into the classical pancreatic or small bowel neuroendocrine tumor that we've all been thinking about. And that allows us to be able to go back and say, okay, where did this patient's tumor arise from? Why did this patient present with what we call facial palsy, for example? Facial palsy is when the facial nerve gets affected and the patient can't open or close their eyes properly or can't chew properly because of involvement at the base of the skull to the point where sometimes it can affect the vocal cords, so they present with hoarseness. Sometimes they present with coughing up of blood because it's within the voice box. And in fact, recently we had a patient who actually presented with a tumor that arose within the heart itself. And sadly, this was picked up when he presented with chest pain, and they were about to do a bypass on him, and they were working up, and they said, wait a second, this is not even a clot inside his heart. This is a paraganglioma of the heart. And again, it's just a reflection that it's very important to appreciate where these nerve bundles are. In fact, I'm going to show you a picture of this particular patient. You can see this is his heart with when he presented again with a recurrence. In this particular case, he happened to have disease throughout his chest and within his liver as well. And we were able to go back and find one of his earlier tumors, be able to show you. Remember, our friend tyrosine hydroxylase, the enzyme that allows us to be able to make adrenaline, and show that there is loss of SDHB, that he specifically had the paraganglioma syndrome. So I'm going to skip this very quickly. Our group has tried to work with the NIH group and actually now have devised a specific protocol that hopefully helps doctors and pathologists to be able to create what we call a synoptic report. A synoptic report is one that is complete, that has many elements in it, and identifies the possibility of different features so that it looks something like this, and the pathologist then is required to actually think and correlate the findings with what the clinicians and the radiologists are telling him, so they can fill out all that information, and if they don't complete the report, they don't get paid. It's not a very popular idea, but really exactly, there you go. And I'm a believer that you don't get paid halfway. You either get the job done right, or if you don't, yeah, there you go. But more importantly, the reason why we say that is because we're insistent on what we call the clinical pathological correlations, meaning that when the patient presents with a problem, the information we obtain from the patient from the imaging is really what guides us on what we measure in the blood and the urine. The profile in the blood and urine identifies for us what the possible genes might be. This allows us to focus on which genes, and then from there we can actually predict what abnormalities might be in the family and go back and do this in a very systematic, focused way, not by creating more anxiety, but in fact by identifying those who are not. Because remember, if you've got the condition, and this is what we call autosomal dominant, there's a 50-50 chance. So that child stands a 50% chance of being negative, in which case they don't have to spend the rest of their lives with that worry or that anxiety in the back of their minds. So, in the end, what I really wanted to summarize is that accurate diagnosis is absolutely critical, and that not all neuroendocrine tumors, and not any more than any type of tumor, is exactly the same throughout. It's very important to really identify this information early on so that when we work with our surgical colleagues, the patient is appropriately prepared. We don't want surprises. We don't want crises. We want to avoid potential crises. We unfortunately do not have very good therapies right now to actually apply systematically after surgery that will prevent the disease. And indeed, chemotherapy is generally not very effective. There is some information, and we have a clinical trial going on at Princess Margaret right now to use sunitinib. Unfortunately, this is in the context of patients who have failed other therapies where the disease continues to progress and has spread all over. It controls the condition, but it does not eliminate it. My belief is that the right way to address this is right at the top, get the right diagnosis, find out who's at risk, identify those patients, send them for surgery early on, have targeted approach that has the potential of being curative. Dr. Khalili also mentioned MIBG, metiodobenzoguanidine, which actually is an analog for tyrosine. That's what the body uses to turn tyrosine hydroxylase activity to produce the adrenaline, and that's how it gets, as he mentioned, it gets internalized, it then emits the radiation that we can then scan. The reason why I'm mentioning it is because one of our efforts, and hopefully Louise and Jackie and others who will continue to work on these efforts will allow us to be able to bring to Canada not the diagnostic MIBG, but the therapeutic one, so that now, instead of giving a very small radiotracer dose for diagnostic purposes, we can couple it for the purposes of being able to specifically deliver iodine-131, which is a form of radiation specific to this tumor, to kill a tumor even when it's in bones. And we've had to send patients to the NIH, unfortunately, for this type of treatment. So this is both a diagnostic as well as therapeutic, in the same way that peptide radioreceptor therapy with octreotide, where gallium-68 is used for the imaging purposes, and then lutetium-177 for therapy. So this is another example, but I just want to emphasize, because you may have heard of some people getting MIBG therapy for their NETs. And some people may have had it repeatedly. And I always ask our medical oncologists, did you actually consider that this patient may have a paraganglioma? And they say, no. The patient had MIBG therapy for the NET. And I say, well, remember, paragangliomas are types of NETs, and if that patient's MIBG scan really was positive, I think it is your duty to go back and really re-examine this patient, find out a little bit more about what caused that tumor in that patient, what else to expect, as I mentioned earlier, and I give them the whole story, and then they hang up on me. So with this in mind, the take-home message is that these are not potentially benign conditions. While they can be benign and they can be sometimes relatively straightforward, the past information has always been that, only 10% are malignant. That is not true. We're now beginning to appreciate that in many conditions and families, anywhere from 30 to 50% will be malignant. So this is a bad situation to be in. We want to be able to preempt this, identify it early enough so we can do something about it. We now know the different potential actors, the different genes that is. We can correlate the biochemistry with the genetics. We can figure out what else can be wrong with that particular patient. And more importantly, we can actually give a patient sometimes very good news. And that is to be able to make the distinction between different primaries from metastasis. And I want to really emphasize that point. So if you happen to have two tumors, how can you tell, and sometimes as radiologists they have a very hard time, can you tell whether these represent one tumor that has spread to different parts of the body, or if we can identify them on the basis of the genetic signatures, we can actually tell that these are different tumors that represent different primaries occurring at different times, and that patient can have resections of these and actually be in far better shape than if they had metastatic disease. What we do know is that if it happens to have features of invasion outside of the ganglion, that is the true definition of metastasis, and that has to be treated appropriately as well. So again, it's a double-edged sword. Just like any truth in life, it has the good and the bad. But more importantly, it gives us the power to be able to make these decisions. And ultimately, it's going to be the patients and the physicians as a team that work together on really being able to apply this information in a rational fashion. So I hope I did not confuse you. I hope what I did is giving you sort of some idea. I know that there are many efforts now trying to bring fields and paragangliomas into the neuroendocrine world, and I know that there are several sort of smaller and larger organizations that are really trying to blend together, and certainly my vote would be that the more integrated and the more united the fronts are, the more effective we're going to be. Thank you very much for your attention.
Technical person is? Oh, here you are. He's not our technical person. Actually, I should introduce. This is Rico, our new patient coordinator with CNETS Canada, and he's acting as our laptop guy today. Thank you. This is what happens when you work in a small organization like this. You become a man of many hats. Dr. Law is next. So I'm going to go ahead and start introducing Dr. Law as Rico pulls up his presentation. He is the chief of the Odette Cancer Centre and regional vice president of Cancer Care Ontario. Dr. Law currently holds several leadership positions, including being the Cancer Care Ontario head and the regional lead of surgical oncology for the Toronto Central North, and the chair for the gastrointestinal oncology site group at the Edmond Odette Cancer Centre. He's a cancer surgeon specializing in hepatobiliary, pancreatic, and gastrointestinal surgical oncology. Dr. Law completed his medical school training at the University of Toronto, after which he traveled to McMaster University to complete his general surgery training. He returned to the U of T to complete his surgical oncology training and went on to Cambridge, Massachusetts to complete his Master's of Public Health at Harvard University. Dr. Law has served in many roles, including being national chair for several Canadian cancer groups, co-founder and director of the Susan Leslie Clinic for Neuroendocrine Tumours, a member of the program in evidence-based care for gastrointestinal oncology at Cancer Care Ontario, and an examiner for the Royal College of Physicians and Surgeons. I think among our community, he's probably known as the most entertaining doctor and surgeon, and like many, and those of you who have never seen him speak, you'll know what I'm talking about very soon. And like the other speakers before him today, he's definitely shown passion for our patient community, coming out to these patient education sessions and always going above and beyond. So on that note, Dr. Law.
Thanks, Jackie. You know what? I'm just like, I'm not that interesting, actually. And usually the fun talks are because I finish both cups of coffee, but this time it's only a cup and a half, so maybe I'll take a little edge off. All right. Well, thank you for letting me hang out with you guys today. And really, what I want to do is take you through the kind of net surgeries that I do, but it's not so much for what I do. I'm hoping that the messages about how complicated it is sometimes to figure out how to do the surgeries and how important it is to partner with you as patients to pick the right surgeries, that's what's really important to me. So hopefully that will come out as we go through the day. Now, I'm a GI surgeon, so it's a digestive surgeon, so for me, I'm going to go take you through that. And then hopefully after you sort of see some of the nuances of surgery today and the things that we have to do, that'll make more sense of why I'm going to try to put that into the context of a team. And I think that's really, really important. And I thought I'd end off with a few questions that might be useful as a little list for things you want to ask before your surgery and things you want to ask after. Like, you know that sponge thing? Did you take it out? Okay. All right, so going from head, whatever you put in your mouth eventually comes out to Lake Ontario, and so that's the same route we're going to take today. All right. For us, surgeons always try to say this, like the primary modality of cure is surgery. It's obviously one way to keep giving us lots of attention, but the other thing is to always remind ourselves, in a way, our responsibility. But NETS makes everything a lot more complicated, okay? Because whenever we say surgery is the primary modality of cure, a lot of times all we think about is, okay, cut it out, and then, you got a chance. It's not so straightforward here. And in fact, one of the things I want you to see today is how complementary and important surgery is as part of all of the care. And many of the things you heard about this morning, including with my partner in crime, Simran, early this morning, because we run the clinic together. Let me give you one example, starting from the top to the bottom. Let's start in your stomach. A lot of times people are told, and more often than ever before, that they have a neuroendocrine tumor or a carcinoid tumor or whatever they're told in their stomach. Now, believe it or not, there's actually 4 types. So I'm going to go through them really quickly, but show you why, again, all the talks you heard today, I'm hoping to kind of tie in. The pathologist important, the radiologist important, and then the last guy that shows up with the one single cycle of stainless steel is important, but we all have to work together on this one. So let's go through this. So the first is a type 1. And this one is common. It is the most common, fortunately, and it's not that aggressive. They tend to be small. They can be removed just with the scope. You don't even need surgery to remove some of them. And if they really do give you trouble, there's only certain situations in which we would really think about doing surgery on you. But because we understand them a little bit better, we know that the surgery should, here's what it should do. It should remove the tumor, but it should preserve the function of your stomach. So you shouldn't be losing a lot of stomach. You know, sometimes you think, just cut it all out. Well, there are consequences to you, not to the surgeon, you know, like the tattoo artist that says, I won't feel anything. We don't feel anything either, but it's really important to us that we design the surgery for you. Now, here's the crazy part of this. Crazy part of this is to diagnose type 1, you actually need to have biopsies of the normal tissue around the neuroendocrine tumor. So again, you know, we need to educate our gastroenterologists, surgeons themselves, if they scope, need to be aware of this, because what happens is these arise in the setting of a special kind of inflammation that happens in the stomach. And if we see that and we see this tumor, we can put it into context and say, okay, small neuroendocrine tumors that arise in this kind of surrounding are a bit safer, and then we can follow or do more limited things that are customized for you. And yes, we can help you with this. And no, you don't need a lot of surgery for this. And yes, you should have good function with this. On the other hand, if you have a type 2, it looks very similar. They're a little bit more aggressive. They happen in a similar setting, but then telling your story is important, because for these people, it's kind of connected with the family history. And that's important not only for you and for designing the surgery for you, but obviously important for the other members of your family who may have other syndromes associated with this. So again, we all have to collaborate, but this, what I like about type 2 is it means that also it's important for physicians and patients to talk to each other and get a complete history. How about type 3? Now, type 3 and type 1 is where people like me who do gastric nets have to, like, this is what makes us scratch our heads. We kind of got to be right about this. Because if I was to just biopsy the neuroendocrine tumor alone in the stomach, a type 1 and a type 3 would look very, very similar. What's different is that they occur and they arise in a different setting of the normal stomach. So type 3 happens in a situation where the stomach doesn't have that special inflammation. Why is that important? Again, it's important because these tumors act a little bit more aggressively. If we're going to operate on you, we need to start thinking about operating on more than just the stomach, because these tumors, unlike the first one, do have a tendency to go toward your lymph nodes. Now, although it'd be great to put in one of those high-quality German stainless steel zippers in you and just sort of go back and forth and look for stuff, we really do try to operate as much as we can in one setting, not multiple times, if we can. And so anything we can have, any information we have to understand before planning your operation really, really helps. Now, I can tell you, the lymph nodes are not critical to your life, but it really changes the surgery. And in order to get all those lymph nodes, it changes the amount of stomach, to be honest, that you would lose in any given surgery. So again, major implications for you, for the discussion that you'll have, for what to expect after the surgery, and obviously for us in planning. And then the last type is a type 4. You know what, if you start going through the internet, once you get past 3, we have a little bit of debate about how you classify the rest, but this is the simplest way. The type 4s are a much more aggressive tumor. They grow very quickly. They are still related to neuroendocrine, but they are what we call poorly differentiated. So when we do the biopsies, the pathologist recognizes a slightly different pattern. These are not often the best tumors for us to operate on. These can sometimes respond well to chemotherapies, whereas the first 3 types don't respond to chemotherapy at all. So there's no need for you to get any kind of chemotherapy, whereas this one does. And it may be better sometimes for a surgeon not to get too trigger happy. This is a situation where maybe you should not have surgery right away. You should look at chemo that might actually shrink the tumor. Problem with surgery is we want to combine all these treatments together, but there's a sequence to everything. If I were to operate on you right away with a type 4, you would need about 4 to 6 weeks before getting more chemo, and surgery doesn't often, or I should say, is not often capable of removing all of this tumor completely because of the way it spreads around. But again, getting the right treatment for it will give you a very good benefit without having things that are not made for you. Now that's just a decision for surgery. I just wanted to show you a table I go through with the trainees to show you that that's just what we talked about. That is, for any given type, for any given key pattern, what, should you do surgery or not? But actually for our trainees today, there's the next part of the table, which is actually not only deciding whether you should do surgery or not, but deciding the type of surgery you should get. So clearly, if you don't need a big incision, and you can get a laparoscopic type procedure, you should. In some cases that's possible. In some cases it's not as easy or requires a higher level of laparoscopic skill, which not every surgeon may have been trained in. And for those of you who don't understand laparoscopy, it's basically doing all of your surgery under a camera. Usually the camera goes through your belly button. It's like the way they do your gallbladders nowadays. But when you try to do something a little bit more complicated than the gallbladder, that takes a little bit more thought. So the fact is, we have a little table. It's not always easy to get it straight, but you can't get through that table if you don't have good pictures, if you don't have good pathology, and then, of course, if you don't have a surgeon that can understand how to take that information and where it fits on that table. So if you have a gastric neuroendocrine tumor, to summarize, there are a lot of important things. The biggest thing, get your diagnosis right, make good decisions. And there are lots of very reasonable things to do for some of these, which can sometimes scare patients. The word surveillance or just watching it or just keeping an eye on it can be very difficult because, again, you've got to understand why you're doing it. And, again, you need a surgeon that will spend the time to make sure you understand. Because I think that if our patients understand this, it's a lot easier to get through this stuff than if you just get kind of told, this is it. So there you go. Now, the next thing, and this is even more common than stomach neuroendocrine tumors, is the small bowel neuroendocrine tumors. And I think this one is one that often people have had symptoms for a long time, and it takes average of a few years for people to actually figure out this is what they have. Because this is part of the body that's actually quite difficult to see. We get gastroscopies, we joke about colonoscopies, we joke about rectal exams. Listen, if somebody did a rectal exam on you and said there's something in your small bowel, it wasn't from the rectal exam, I can guarantee you. That's pretty far away, unless it was really uncomfortable, but let's not go there. Okay. The fact is, this is sort of like the dark side of the moon in the body. For a lot of us, you can't see it with a scope that goes down here. You can't see it with a scope that goes up here. So you got to have some sharp doctors who start suspecting maybe there's something. And then you know what? You need someone like Dr. Kalili to be sharp as well. So let me show you an example. You've seen a lot of imaging today, so I'm not going to go over everything, but this one is just sort of striking. This is a typical CT scan. It was done right. It was a standard CT that most people would get if they have tummy pain or some problem. And what it shows you is all that white stuff that you see there. That's that wonderful drink. It was kind of chalky. It's at 2002. It looked like a good year, but it didn't taste that good. But it all goes through you, and that's how we do a standard scan. But when you do this, you wipe out any evidence of a small bowel neuroendocrine tumor. Watch. Let's do it a little differently. So the right way to do the scan for somebody where you're thinking they may have a small bowel neuroendocrine tumor is one where you use this negative contrast. It's not the normal contrast you use. This is actually a very simple concept. It's just basically using the same bowel prep they make you drink when you do a colonoscopy. But that stuff doesn't turn white on density on a scan. Now, if you combine that with what Dr. Kalili talked about earlier about giving that contrast, if you do it exactly at the right time, and you drink the stuff at exactly the right time, what it does is stretches out your small bowel, and the neuroendocrine tumors, they have a lot of arteries, you just heard that, and they pick up this contrast, and then all of a sudden you get little light bulbs. Now this was somebody who had been operated on before already and was told that they're clear of their neuroendocrine tumor. I don't know why you're still having symptoms. And yet when we do this type of scan, which is called a CT angiogram, there's another one, there's another one. There's many more. We ended up reoperating on her, and there was still lymph nodes that were positive for neuroendocrine tumor and 8 further neuroendocrine lesions in her small bowel. So, you know, I don't want everybody to start examining their abdomens right now, okay? But the fact is it requires very precise imaging. It requires your doctors to actually talk to each other, because if I send Dr. Khalili a request, CT scan, abdominal pain, question mark, like that's really not helpful. I mean, how is he supposed to know what he's looking for, etc.? And so those are the really, really, really important things that help your imaging come through properly. Now, the small bowel is a little different. What's different about them actually than most neuroendocrine tumors is size doesn't matter, which is good for a little guy like me. So the issue here, though, is that the reason it's so important to do that mapping of your bowel is because, you know, surgeons get distracted. You see a big lump, you kind of like just go. It's like that movie Up where it's squirrel, you know, anyways. The thing is we can't do that because here we need to do a map. At least a third of people with a small bowel tumor are going to have multiple tumors. And it's really important that we try to encompass all of them because it could be the smaller one that's eventually going to give you trouble. If you don't have a spot in your liver, for example, it might be the smaller one that's the one that's going to spread up to your liver. So these are tricky things to do and important that we do everything that we can to map it out, which is what you saw earlier. Then there's another problem. The other problem is where it's located and the fact that you have a lot of blood vessels and they're all interconnected. Now, small bowel tumors related to neuroendocrine tumor, they like to go into the lymph nodes. These lymph nodes are like filters through your body. You know, just like little filters, and all they do is just pick up stuff that they don't recognize and try to hold it up there. If it's a piece of bacteria, it holds it up there and then tries to eat it. Unfortunately, if it's a piece of cancer, it holds it up there, and then the cancer starts fighting it, and sometimes the cancer learns how to grow in the lymph node, but the lymph node itself is actually trying to hold everything back. Now, for any given surgeon, if the red spot here was your tumor and these green things were your lymph nodes, we have to start thinking, okay? We have to start thinking not only about surgery, but what other treatments are left. Now, let me show you some examples. So if we did a little surgery like this, okay, then it's not really complete. We still have these lymph nodes that have tumor in it. We've gotten rid of this problem, but over time, if these continue to grow or progress, they can lead to other problems. And the other problem with small bowel neuroendocrine tumors is even if they don't grow, some of the things that can happen if they don't receive treatment is they can cause scarring. So they create this kind of response. I don't know how to describe it. It's not really like an allergy, but something happens. Your body starts to pull everything in, like it kind of just scars down. The problem is, as it scars down, it's going to pull more bowel in there. It might give you another bowel obstruction, or pull these blood vessels in and actually can cut off the blood supply to part of your bowel. So those are all bad things. So you don't want to leave this in there. Okay, so then let's go all Japanese samurai style and take everything out. Well, okay, now there's another problem, okay? Because another big problem here now is now you don't have enough bowel, okay? This is a disease that we can control. Now we went too overboard, and now your bowels aren't going to work. Well, you know, anytime you do surgery on the bowel, it doesn't work quite right. But I can tell you this was even worse. You can have major digestive problems and food absorption. And now I may have cured you of the neuroendocrine tumor, maybe, but I don't know what I've left you with quality of life. Now, this is tricky, right? So, you know, the hard part I found is like trying to decide this with a patient while I'm operating them has been difficult. In the old days when we used a wet towel for you to bite on while we operated, you could say something to us. But apparently now we have to give you anesthesia, you have to be kind of like quiet, and then the conversation's really one way. So what do you think? You know, So we can't do that. We have to be much more planned. And again, goes back to why the CT imaging is so important. The less decisions that you need to make in the operating room, the better. Also, for our patients, the more you know, the better. So the right thing in this case might be a fair amount of tissue removed, but a critical one that sits on that main blood vessel, maybe it's better, part of valor, to leave that in. Because I have friends, like Shireen, who can help me, like Simran as well, who can help me with other options here. Now, we may not be able to get that one out. We know where it is. It's monitored. I mean, we try to get these things out. We don't just like, you know, it's not, but let's say it's really in a position where it's dangerous to you. we know that what we have to do is get rid of as much as possible so that if Simron's going to give you octreotide, which he talked about to you this morning, the sandostatin, etc., or other kind of medications, that number one, it will work for you. It will preserve more of your quality of life because we've given you better function. But I've also left a little amount of tissue for the drugs to work in. And we do know that if there's less stuff for the drugs to work in, they're probably going to work longer, probably a little better. So all of that said, that's where, that's why it's important for surgeons to also understand what the other treatments are other than just the surgery itself. So, I mean, that's what makes this kind of surgery for neuroendocrine tumor a little bit trickier than other ones. The appendix is also a common spot, and unfortunately a lot of young people with appendicitis come in and all of a sudden they're told they have a tumor in their appendix. The big thing there now, for appendix, it's all size. So this is why you gotta, like for surgeons, it's not all neuroendocrines are the same. So as I told you in the small bowel, where size doesn't matter, sometimes the small one that spreads and we spend all this time looking for it, all of a sudden the appendix, it's reversed from the patterns that we know. So if you have a tiny little appendiceal tumor, it's probably not going to affect you compared to a bigger one. And the biggest question with this is, do we take more of your bowel out? And this is an important question, especially if you're 23, 31, or even if you're 85. It's all important. But because the reason is the tissue that you're going to take out, okay? If you think this is an aggressive appendiceal neuroendocrine tumor, the tissue you take out is a very important part of your bowel that usually absorbs a lot of water. I know many of you know your colon reabsorbs water, but in this case, the right side of your colon does a lot of that work, and there's also a valve that kind of slows things down as it goes there. So if you take this out, we're going to change your bowel habits, for sure. Now, some people adjust with time, other people don't. But again, you kind of take it seriously. You don't want to just take out things that you don't have to. So there are very specific criteria that we use to try and help us understand who is going to benefit from an upfront surgery and who doesn't. Finally, if you're somebody like this, remember if there was another word I could put, if I could teach you, if you get told, let's just do surveillance, that is, we'll keep an eye on you every once in a while, think of that as your insurance policy. Okay, that somebody's interested in you. It means your risk is low. It means that, God forbid, if something comes back, that what we're thinking is that what's going to come back is either slow or small, and that we can detect it early. And then we kind of use that because you don't want to just give up that part of your organ if you don't have to. You only want to give it up when something shows up. And so sometimes we have that option, and that's what it is. There's a little box in the corner here that I always point out to our trainees, is that unfortunately one of the things about something called the history of medicine is that things get called in a confusing way. There is a tumor called a goblet cell carcinoid. It really has nothing to do with neuroendocrine tumor. It really probably has more to do with just a straight up colon cancer. And so sometimes the words are very confusing for people, and it's our job to sort of sort it out and then go and talk to the pathologist about rewriting their language. Okay. The last one that I do want to go over in terms of a GI primary is rectal neuroendocrine tumor. And you know what? Honestly, there's more and more of these. Probably not because there's more of them forming. Probably because we're doing more and more screening colonoscopies. Also, as a province that has an official screening program for colon cancer, you're going to see more people with this. The trick with this is trying to figure out who is somebody that needs more surgery and who doesn't, because a lot of these are very quiet. Now here's something a little weird. They also behave a little differently. They don't, even if they are advanced, give you something called carcinoid syndrome, which many of you know about, where you get flushing, etc. It's a different kind of neuroendocrine tumor. It doesn't make that kind of chemical, which also means that you can't detect it in the same ways as others. So if you're doing your urine screening tests that you normally do with appendix tumors or small bowel tumors, urine screening test here is not so useful. So things for physicians to think about. Fortunately, the vast majority of these are very small, again, can be removed with the scope. These ones, your doctor is allowed to tell you to have one of these after a rectal exam, if that's what he feels. But the big thing here, and the reason I showed you this picture, okay, is if you have one of these, one of the good things that you should do is to leave a tattoo there. Now, I know you can't pick from a book with angels or, flowers, roses, and other favorite names, but you do get a big ink spot It shouldn't, no one else except your colonoscopist should see this, but the point is that incredibly your body heals really well. And some of these rectal nets are very, very small. And you'll heal right over it, and you'll never find that spot easily again. There are tricks that we have. There's special ultrasounds that we have that can look through those things. The point is, the easiest thing is, if it looks like a neuroendocrine and you remove it, you'll leave a little mark so that you know where to go again. Fortunately, a lot of these, if they're completely removed, even if they didn't leave an ink spot, you're okay, if they're completely removed. Now, for those that have bigger ones, these act like rectal cancers, like regular rectal cancer. And you should get a treatment and a surgery like regular rectal cancer. The only thing that you do have differently is you won't have the same kind of chemotherapy that rectal cancers patients often go through. It's a little different. And again, you'd see somebody like Simran, but he wouldn't be necessarily giving you any chemo. But, you know, once the tumors in the rectum go over 2 centimeters, the likelihood of them going to the lymph nodes are higher. Fortunately, like I said, very few are over that size. And again, in this case, size does matter. All right. So the part that's really interesting about these kind of tumors in a way that's changed over the last while is, now I've talked to you about where they start in the digestive system, but they often, because they don't give you a lot of symptoms, or because people can't diagnose it, or you already appreciated that some of the tests are tricky, they do spread. And a lot of people, you know, the tumor has already spread by the time we've seen them. So what I want to go through with you today is to try and help you appreciate that, one, there are options of treatment. They're complicated, so I'm going to try to make it as simple as possible, but to help you appreciate what we need to do for it. Okay? The first thing is this. A lot of these are from small bowel. Usually, that's the most common. They do something not so nice, is that they make a lot of serotonin and they kind of hold it all up like a big storage reservoir. And when your surgeon goes in and operates and manipulates things, things start to release a whole bunch of this hormone right while we're operating. And it can get really complicated. So you don't, if you're under a general anesthetic, theoretically you shouldn't feel anything. What you see for the anesthetist is your blood pressure, your heart rate, and all those things start to fluctuate wildly during the operation. And remember, the anesthetist's job is to keep you as comfortable and stable as possible while the surgeon is doing something. So, you know, if you're going to get an operation for this kind of situation, you've got to be in a system where your anesthetist also knows the situation. Maybe he doesn't need to know how to take out the tumors, but he or she sure has to know how to handle these hormone rushes. So just wanted to show you, this is one, for example, protocol of what we do in the operating room for patients. And, you know, for us, we try to keep it very straightforward. I know it looks long, but actually here's what's straightforward about it. It really goes through the 3 situations that most people present. So the first one is people who are already controlled with Sandostatin LAR, who are under a controlled, and we're kind of bringing you in a controlled setting where it's planned, etc. That has a separate protocol. There are people who are already on Sando but aren't well controlled, and that might be part of the reason you're having surgery. And in that case, we have a different protocol for that. We know you're on Sando, we know you have some control, but we also know that your hormone levels are still high despite it, and then we have to factor that in. And the final thing, which is fortunately rare, people who aren't on any kind of hormonal control at all came in like an emergency because of some problem, and then we subsequently figured out, as we're taking you to emergency surgery, that you have a neuroendocrine tumor and a potential carcinoid syndrome. So that I have a different protocol as well. Again, the other thing is, without getting too sophisticated, that we're starting to go and do more in your liver because, well, our radiologists are helping us. I'll be honest with you. The better the map we have and the better the understanding we have, the better. What is this picture for? It's just sort of very simple, somewhat 3D reconstruction, but the point is it's trying to calculate volumes. If we were to do a very aggressive liver surgery on you, how much volume of liver tissue can we leave behind? So believe it or not, your liver is an amazing organ, okay? Now, I'll put it to you simply. I could tell you that when each individual of you has a discussion about liver surgery, it's a lot more complicated than this. But you can literally leave about 20% of your liver behind, and it will grow back. Now, it is not that it will grow back the pieces you took out, but the piece you left in will grow bigger and bigger and bigger until the volume of liver tissue that you have is almost equivalent to what you started with. There are things that affect that. if you have any kind of liver scarring, or I hate to say it, but if you've been a heavy drinker or you've had hepatitis before, all of those things can affect your liver's ability to grow back. Those are complicating things, and that's why we kind of need to know, because for every given situation, the volume of liver we leave behind is a little bit different. The other thing we've tried to do is bring the imaging into right while we're operating. So just for those of you who like this kind of fun, this, I don't know who that idiot is in the picture, but anyways, we created a system where we developed a sign language for the Microsoft Kinect camera, except Microsoft allowed us to hack it, so it's now connected to our operating room computers, and so without playing with the mouse or touching anything that, and definitely no junior mints, we don't have to touch anything. We just hand signal. Sorry, that was a joke from Seinfeld. But you just hand signal this, and the imaging moves with you, and then it allows you to do something like this, which is in this case these are all the individual little bottles. I'm not sure why we sent it all individually that day, maybe to torture the pathologist, but these were all individual tumors from one person. All right, so neuroendocrine tends to spread. They spread into little places. They go all over. And we really do our best. Not all our patients are I would say candidates for this, but when you are, I go back to my original point. If we're going to operate on you, we really try to do it once. Okay? So a lot of times you'll see that we do a lot of planning. So we found that this is pretty difficult it's difficult for us to understand sometimes, and for many of you, especially if you're not near any of the big teaching hospitals, you'll find that your care is passed from one to another a lot. Partly because depending on what you have or your situation, your needs are different. And so at one point a few years ago, we actually wanted to know and get an idea of what patients were struggling with. So we actually called a few of our patients, and these are kind of open-ended interviews. Any of you who are into qualitative research will think I'm just destroying the science of it right now. But the point was trying to figure out, without asking you terribly specific questions, whether there was something common. And so the common themes that we found, I'm sure a lot of you in the room would understand, is that first, everyone had a problem with getting diagnosis. There was a common theme of getting appropriate information, that you would get different information from different doctors. Then you wouldn't know where to go. How do the treatment centers work together? And then again, difficulty, well, maybe this was before CNETS has been so strong now, but they had a lot of difficulty finding disease-specific support, because going to a breast cancer session really didn't appeal to a lot of the people. And the final thing was that there was no clear pathway. They couldn't understand what the plan was. So all of these things were kind of really, really important in figuring out what our patients needed. And as we took this forward, and we still are, we try to always keep this in our minds to help our patients. It's not always easy to fix all of these things. Now, one thing I can tell you in Ontario that's really improved is this whole thing about finding treatment centers and stuff. I mean, I don't think I talked to Shireen more than my wife. I had to think about that for a second, but it's getting pretty close in the sense that we've tried. Yeah, see, I caught your attention. No, but what I was really trying to say is that we've made a commitment. So in Ontario, for example, there's really 4 major centers identified as having interest in this that has told the Cancer Care Ontario, i.e. the cancer branch of the Ministry of Health, that they want to do more of this. These centers now are on video link at least once a month to talk about all of their more complicated patients. I don't think we could talk about all our patients, but we certainly create a forum to talk about each other so that we do 2 things. One is for our patients know that we're humble enough to ask each other to double check our plans. The second thing is that it helps all the centers give even treatment, because we're always sharing regularly what each center would do. Ultimately, like you would with any family, if you had 5 family doctors with a simple problem like hypertension, you probably get at least 3 or 4 different solutions. You may still get that, but I would hope that they are just shades of gray, not that different from each other. It might just be a little thing like dosing or the way they want to give it, rather than any major plan like, no, you should have surgery, or yes, you should have surgery. So these are things that have happened since this survey to try. And we still have a long way to go, but it was really important, especially for the surgeons, to have access to this, because it's really important to understand it. So even though when you go to a big center like ours, we have 250,000 visits from cancer patients through the Odette Cancer Center a year. Like, it's easy to get lost, right? And I always laugh because I grew up in rural Eastern Ontario, and I asked our HR how many people work here, and they said 11,000. I said, well, that's 10,000 more than where I grew up. So there you go. So, you know, we had like, you know, 2 corner stores, which I thought that's what a grocery store was. My first visit to Loblaws was quite the experience. Okay, and of course, this is our property. It's huge. And the other thing is, the biggest problem that we have, for example, is, well, this is where we are today, smiling. But this is where my office used to be many years ago. And this is where all the medical oncology is given. And the best thing we've done is, and it's difficult because when you move in together, there's all sorts of, Simran's not here. Usually I make some joke about living with Simran, but, and then he sort of like whines or something. But anyways, we moved from here to here. There's always growing pains, but it was important, not for us, for our patients, to co-locate the doctor so that you constantly push them to communicate with each other. And then the even harder thing was to convincing doctors to change what day of the week they see patients, right? We actually asked that all disease sites, including neuroendocrine, try their best to move on the same date together. So even if you're not booked to a medical oncologist, so you see a surgeon and we say, oh, wait, you might need a medical oncologist, we're trying to limit the number of times that you have to come back on another day. Now, it still happens, but that's part of the goal to the same thing, address the issues that we've heard from our patients. And that is where the clinic came from. And there's lots of different ways to get into the clinic, but the point is that you all end up in the same place. And we're very grateful to Susan Leslie, who's one of our former neuroendocrine patients, whose family has put some investment here to help us establish this. And having a clinic to coordinate your care is important. Again, the reason it's not treated everywhere is this is where what we do all over Sunnybrook across the entire property. And you can see that, you know, we were just talking the other day about creating like little stickers with different colors because people, like, between all the different tests they have to go through, navigating a place like this can be very complicated. All right? I don't think I can emphasize, if you haven't got it, communication for your physicians are really important. And if there's anything else I can emphasize today to follow up with everybody else is how important it is for you to have more than one physician with different specialties, okay? And that those physicians should always look at it as a teamwork and as people who work together for the betterment of you, and then you know that you're on the right track. Now, these are 10 questions I always say that you should ask before, at least I asked before. First off, like I said, you should know that you have a neuroendocrine cancer, okay? You need to know that. And how do you know that? Well, sometimes if you've got your pathology report done at a hospital that doesn't see a lot of neuroendocrine patients, it might be important to have your tissue sent over for a second review. This is not to insult anybody's work. It's not that these are sometimes rare. They're hard to. They're not always easy to figure out. I think Shireen was awesome at showing, you know, some of the strategies we're putting in, such as synoptic reports and holding back money from pathologists was the other strategy I heard. But whatever it takes to get that, but it's still, you know, even sometimes we report it. Now, Shireen and I work so close together between PMH and us that, you know, we've actually have a lot of combined reporting. Many of the neuroendocrine tumors I do, it's actually one department that looks at this whole thing, so we have a higher level of confidence that we're giving you the right answer. The other question is, it's funny, I find patients often want biopsies. You don't always need to have a biopsy, but sometimes you do, and you should ask about that. And it's sometimes, why do I not need a biopsy, and sometimes why I need a biopsy. The point is that whatever the answer is has to be attached with a plan. If you're getting a biopsy because they want to know what it is, that might not be the best idea. A biopsy is to put a little needle in something and remove some tissue. Sometimes your best plan is the imaging is so good, you already know what it is. So I can do a biopsy too, but I also actually, you know, remove the tumor at the same time instead of poking a million holes in it. But then there are times where something looks weird on the tumor. And then remember what I told you? Sometimes surgery going in first is not the right thing. And that's when you need a biopsy. So it is hard. It is a good question for patients to ask. The answer that comes out should make sense. You know, I always say that you can have confidence in somebody if they can explain it to you like a 6-year-old, because it takes actually a lot more effort to do that than it is to come up with some really, really complicated answer where half the words you don't understand. But you do write them down because you're going to win that next Scrabble game with some of those new words that you learned. All right? The next thing is you should ask if biomarkers were done. Okay? You should have some idea before the surgery what your levels were like or whatever. In fact, I always tell people, you should know before I cut it out because I want to know it went down after I cut it out. But if I don't have anything before I start, how do I know where I ended up or how effective the therapy was? So that's another thing that's important. The other thing I always say to ask is, feel free to ask, how can I get ready before an operation? I don't know. Sometimes not everybody asks that. Sometimes they just go home and they kind of go into like the worst thing you can do, by the way, to prepare for surgery. I guarantee you, is to sit on your chair and start Googling for 23 hours of the day. Guaranteed. That's the worst thing you can do before your surgery. Why? Because you're getting out of shape quickly. I find that Googling for 23 hours requires peanuts, chips, and other things beside you. Lots of pop, Red Bull, or coffee. All things that are not good. Listen. During your appointment, take the time, figure it out. If you're going to go for surgery, the moment you decide, get outside, get fresh air, start getting active. The biggest difference you can make to getting over your surgery is improving your respiratory system. So what does that mean? That means if you go to, well, it's getting cold, so let's talk about a mall. If you walk up the flight of stairs at a mall and you get to the top and you're less short of breath at the day that you decided surgery to the day that you're about to have surgery, you know you're going to do better. You do not need a personal trainer. You do not need Arnold Schwarzenegger muscles. You don't need that. You just need a little bit of endurance, a little bit of the air pockets opening up, all of those things. Now, some of you having carcinoid syndrome can find this is difficult, so you don't need to do like crazy stuff. Just any activity is good. The other thing is, it's not just about your body. It's about your heart and soul as well. And I can't tell you how many times I've told people, do you have a chance to go on vacation? Go. Go. They think it's crazy. I'm like, what? I'm going on a cruise or something before the surgery? I was like, yeah. And then I want you to, well, don't drink like crazy. Okay, so just get that part straight. Don't gamble all your money away or something crazy like that. But I said, whatever you do, your heart and soul is just as important. So if you get told you're going to get a big surgery, then you know what? Enjoy, go in positive, do those things. They don't hurt you at all. They don't take away from anything at all. And you know what? Most of us, we're smart enough together that we can plan this. Like I know the day you make the surgery, you do all the paperwork, then you need to see the anesthetist a few days before, then you have the surgery. But there's this big block of time in between that you could do a lot of other things. You don't have to go on vacation. But hey, you know what? You got a chance to spend a week up in the cottage, do it. Okay, bungee jumping is probably not the best idea. It's cut me off, I guess. There you go. Okay, so hopefully after it adjusts the image, it'll come back up. Sorry, guys. Okay, so the other thing is, are there any medications or hormonal therapy I should get before? Sometimes there are little things. Maybe your Sando dose needs to go up. A lot of you who are on Sando LAR, we actually give you 5 days of short-acting before just to boost the level if you're getting, for example, liver surgery. The other thing you should always know before deciding on surgery is that you have a clear understanding of what you could do without surgery. It doesn't mean you're not going to have surgery. It just means that you've balanced the decision well. You've gone over all your options. So for neuroendocrine patients, you guys have the one dimension that many other patients don't have. Sometimes you have the dimension of time. You don't always have to have that liver surgery next month. It could be 2 months from now. It could be 3 months from now. So just ask about that because guess what? We do the surgery for your life, not for removing tumors. Otherwise, I am just a puppy chasing balls. And that's not what I want to do. I want to help you with your life, and that means taking all of those things into consideration. I can tell you if you need emergency surgery, we're pretty clear. We actually handcuff you to a stretcher, and then, what we do is we tell you, but there are the dimension of time, and that's important if your daughter or your son is getting married next month, and maybe you don't need the surgery right then. Please tell your team so that we can help you the right way. There are lots of ways. We won't plan something that will harm you. But we are doing this so that you have, hopefully, a longer life and a better life. And that's the whole point. These surgeries are already complicated enough. They are really hard to get over. They can have complications, etc. So we want to go into it at least with all of those factors understood. And that where it goes to risks and benefits, you obviously understand that. The other thing is what do you expect in your hospital stay. Like, again, you should know how many days you're about to stay, when you expect to go home, because those things are important mainly from the point of view of just having some expectations. So you don't get worried. So you don't think, are they kicking me out too early, or why am I still here? And then there's always the last thing is to understand your short-term and your long-term effects of surgery, okay? Different surgeries, different things, they mean different things. You should know what to expect in the first week or two. What are things that you should expect long-term? And these you should know before your surgery because it helps you decide. And then you might get asked about different parts of surgery. Not all of you will have all of the surgeries at one time, even though we try for that, because it's a lot of times it's based on your ability or your desire even to tolerate certain side effects. So that's really important. The questions after are similar. Remind yourself again that after the anesthetic, you get the same answers for short-term and long-term effect, or that you remember. You should always ask about how your follow-up will be set up, and it doesn't all. For those of you who are from far away from the center that you're going, you don't always have to have it set up at UHN, Sunnybrook, or the big hospitals. Sometimes you can have your follow-up set up closer to home. And some of you actually should know that the imaging closer to home is connected to a lot of different places. So, just speaking because where I work, that's just what I know. You can get a picture done in Newmarket. You can get a picture done in Peterborough. You can get a picture done at Oshawa. And if your doctor is worried, they call us, and you don't need to send anything. It's all on the network. We just look at it, right? Which actually reminds me, I need to look at one today. I promised somebody from Scarborough that I would look at to help with their tumor board. So there you go. So I don't need to get a disc or anything like that. Now, the other thing that I think Shreen already said is you should always ask, are there any other cancers I need to be screened for? And that goes to colonoscopy and gastroscopy. When should I have those? Are there any dietary restrictions? Those of you having operations on the bowel, you have to think about those. Hopefully you've known about it a little bit before the surgery, but a lot of times it's good to go over it again. Ironically, a lot of times right after bowel surgery, you are told to eat things that you don't normally associate with health, things that are low on fiber and a lot more bland, whereas later on, you can eat more of that. And it's all related to how your bowel heals. Initially, it's kind of swollen up, so the connection is actually a little bit narrow. So you don't want to strain it too much. Later, as the swelling goes down, it opens up, your diet can change as well. What exercises can I participate in? And it all depends on the incision that was made for your surgery. What does the pathology show? Again, there should be some discussion with you about pathology. If the discussion is you had a neuroendocrine tumor and that's the only discussion you have, there's a lot of things missing, like that you've heard about earlier. All those little characteristics of what your cells look like, their pattern, all play into how the treatment is going to happen. Now, not all of you want to know these details, but you should ask a little bit about it, or you can ask it in other ways. Did you use the pathology to determine these options you're offering me? Yes, and then we can go on. Okay? The last one is what markers on the pathology affect my future management. What that's trying to tell you is that there are things we see on tumors that either affect whether we're going to give you more treatment or not more treatment. So, the bottom line is I don't have a diagram. Like, play like where you what do you call it? That surgeon game I played as a kid, where you just don't have to touch the edge or it rings red. There's no simple thing like that, doctor. It is important that all of the nuances of your neuroendocrine tumor plays into exactly what surgery you're offered. And then the final thing I want to say is think more three-dimensionally. What I mean by that is not just if I should have surgery, it's also about when. It's also about when and what I do treatment-wise before and after the surgery. Those are the important factors for your ultimate success going through something like this. So, again, thank you. I hope you've got some more information about what surgery is and how complicated it is. The important part is that you have a team, that you're in the right place when you have a team that is treating you, and the team doesn't always have to be in one place. It can be virtual, but that there's good communication between all your doctors, and that the moment you have surgery, everybody on the team is telling you the same thing. Your medical oncologist, the radiologist, you don't often meet radiologists. They're more shy, except for Krish. But everybody else should all be pointing to the same thing when that ultimate decision for something like a big surgery comes up, and then that way you know you're going for the right thing and that you had the right things before, and that you had the right things after. Thank you.
If you don't mind staying up here. So I don't know. Sure, of course. You go ahead and do what you need to do. I don't know if any of you noticed, but I skipped right over the break so that we could get all the presentations in. So if anyone needs to use the restroom or grab a drink, please feel free to do so. But I would like to move right on to question and answers, because I'm finding at these sessions that often takes up a fair amount of time. So if we could have Dr. Law and Dr. Azat come up, and I'm going to try and find some other mics. Maybe you guys can share this one.
We're gonna.
Wonderful. Does anyone have any questions they'd like to come up and ask? If you don't mind. Here. Why don't we
Is the capture for the webcast too, right?
Well, those with the sound.
You mentioned that there were 4 centers that are active in this. What would they be?
All right, so the 4 centers in Ontario are McMaster, London, and then the 2 in Toronto, Sunnybrook and Princess Margaret.
Thank you.
Anybody else?
While you're getting ready for the question, I do want to tell you that when we have our provincial tumor boards, we actually open up to all hospitals. So we've had calls in from, I think the Brockville once, Kingston often calls, Ottawa often calls, but those are the 4 that are willing to do more advanced treatments as we move forward in the future. But just so you know, the discussions and the video boards and the video links are actually open to all of Ontario. So
I just want to add to that. I actually think that this is a critical point. You know, the rate limiting step is not so much for very large centers like, what Dr. Law was talking about, but really more importantly is that there are many patients out there in the communities that get treated and managed by centers that really have very little expertise in the area, and recruiting them into this consortium, I think, is a major effort, and is going to be absolutely critical in making a real difference here.
Sorry, I'm not holding up your question. I'm sorry. I just thought of one more thing. Like if you are from a smaller community outside, and you're trying to think, and you're telling your doctors about this, and they have no idea what you're talking about, all of this is connected through one system in Ontario. It's called the Ontario Telehealth Network. So everybody in Ontario has some contact with one member of Ontario Telehealth Network. And so the Ontario Telehealth Network, otherwise short form is OTN, is what connects us all together. It also ensures that when we talk about you, it's not captured on a Skype stream or I don't know, FaceTime or whatever. It's on a secure sort of confidential medical line. But it also means that any doctor who calls OTN can find their way to connect to this. Okay?
So what I found with that
Yeah.
is that you question physician, they don't have a good attitude.
Uh-oh.
You're out the door. I found with the 4 of you, you're very open-minded, obviously, because you have that passion for it. But my husband has come across many already within a year that have been just like, yeah, kind of thing.
As soon as you voice your opinion, ask a question.
We found out about this by Googling. I mean, sometimes Googling is a good thing. Yeah, we did our own research. It's sad. Very sad.
So I think you're bringing up an important point, but to be honest and to be fair, and it's not to take any sides at all, I think this is a problem actually throughout medicine, to be honest with you. You can have anything that's got to do with joints all the way to heart disease to everything else. And my view always, and I think that's what Calvin was trying to say, is there has to be an effective dialogue that you're having with members of your team. Whether that's your primary care physician or your surgeon, if it's not working out, then it's not right for you and you need to move on.
The information that you gave today was so informative. Now, I have a cousin who was diagnosed with NF1, so I think it might be very important for me to maybe get tested and double-checked, I think for ganglioma. So I'm just wondering if it would be possible for me to ask my family physician refer me over to you, Dr. Izzat.
Right. So thank you for your comments. I should point out that there are a number of mechanisms by which people can be tested. Obviously, the most important thing is when you have history like what you've just shared with the rest of us, either you can be referred to me, or somebody like me, or we can direct you to other individuals closer to where you live, because really the important thing is to make sure that the test is being done properly, interpreted correctly, and appropriate actions are taken for you and your family members.
So an example for me is I do operate on people with paraganglioma, and I almost send all of them to Dr. Izzat to share together. But their family, I sometimes send them to a genetic counselor or a screen, because the patient who actually has the thing, that's what I asked Dr. Izzat to do. But for those who don't, oftentimes the genetic screening centers, which there should be many in Ontario, you can access those centers where they can start doing some of the workup. And they can always interface with us, but they help us a lot with just getting the screening stuff done. Do you agree?
Yeah. So I totally agree with that. There are a number of certified genetic counselors. They actually have to lobby on your behalf, where they have to send a special requisition to the province to allow for reimbursement. And let me explain why that's important. I think this is a very critical issue. And sometimes people ask me, why don't you just do this gene? And what I have learned over the years is, as you can see here, our knowledge is expanding, and we now know that there are many other genes, and sometimes even within families there are related genes. So if I do it and a test comes back, and if it's negative, if I tell you that you're negative, then I'm probably premature. What I really need to make sure is that other recognized related gene family members then get looked at. So that means that you don't just sort of take the most immediate answer, but you have to look at it more carefully. And that's where we have to go back to the province and say, you know what, we're going to have to spend a little bit more money. Why? Because if we don't, and if we don't get an accurate diagnosis, we're actually going to end up spending more money. Why? Because you're going to have all sorts of unnecessary tests that are appropriate and inappropriate. Meanwhile, you may end up requiring therapies that are also misguided. So it really, in the end, I think the strategy of doing this, as I said, in a very rational, directed, but also it's an evolving area. And that's why I think it's important to make sure that they're aware of the benefits and the limitations, and it's a constant dialogue.
Right here.
Gamma rays are known to cause cellular and genetic mutations and so on. Is the effect cumulative, like the more CT scans I have, is that, I mean, I'm past childbearing age, but...
Well, hold on, let's turn off the lights and see if you're glowing. No, okay, I gotta be serious now. Do you want to?
Sure. So the short answer is it's not entirely cumulative, meaning that really what you do so we have very direct evidence now that you're absolutely right. We can induce DNA damage. And we induce DNA damage primarily by impairing enzymes that are required for the healthy regeneration of abnormal chromosomes, which goes on all the time, by the way. But by the same token, it actually induces genes that are involved in the repair. And generally, we now know in mammalian systems that takes about 3 to 4 months. So it's actually not a permanent effect. And we also further know, for example, that as whole beings are exposed to radiation, we've known from the Chernobyl accident that there was a blip in the cancer risk, but it actually decayed. We also know from other histories of other radiation exposures. So it's not an everlasting, I think, is probably the short answer to that.
The sort of my keep it simple, stupid kind of keep it simple. Is that right? Yeah. Anyways, yeah. Keep it short. Yeah. But general principle is this: you should always get the right. You should always know what the question is before you get your image. Then you should get the right image to answer that question. So if the question is, there's a spot in my liver and is it growing? If you can see it on ultrasound, and you can measure it accurately, then you shouldn't need a CT. Like there should have to be, that's what we are responsible for asking ourselves. But if there's no other way to see it than a CT, then that's what we should do. We shouldn't just be afraid of your radiation exposure and then give you a suboptimal image. So.
Let me elaborate on this point, and I wish Dr. Khalili was here, but unfortunately he had to leave. Although, in fairness to them, I totally agree with Calvin here. In my view, if you're going to do it right. And if you end up trying to take shortcuts, I see a lot of patients, for example, who end up getting ultrasounds of the retroperitoneum, which is the area right behind Calvin here, where all of the spine and the fat and stuff. It's a lousy way of actually looking at this region. You really need a CT scan. And when I get a patient, so that patient has already had this, that, and the other thing, when really the real tests that I can do to definitively exclude what I'm looking for can be done. So I think that the fear of radiation-induced damage has actually created more of what I call futile cycling, more unnecessary testing, and in the end it doesn't really help you.
Other questions?
Thank you, doctors, for excellent lectures. First thing, a very short question. Is PET scan already funded by OHIP or not?
So, I was listening to Rush speak about PET scan, and I was kind of raising my eyebrows in the back because most of you don't need a PET scan. PET scans are not that indicated in neuroendocrine tumors. Octreotide scans are, but they look similar. Okay, it's just that the agents are different.
No, I know that. I wanted to know if it's funded by OHIP or not.
Yeah, so OHIP has very strict indications for PET scanning. If you're interested in FDG PET, okay, I think there's only 5 indications right now. They are related, like I can't tell you right off the top of my head, but there's some, like people with lung cancer, people with pancreas cancer, like there's very specific criteria. Well, I'm not going to sit here today and argue about which is...
Okay, thank you. That's good to know. Second question would be, I always find difficult when I'm going for follow-ups to get my MRI done for pelvis and abdomen at the same time. They are reluctant to do at the same time. They sending me the 2 appointments, and I don't want to go for 2 times and get injection twice, so I'm trying to accumulate. What's the challenge there?
Okay. Well, MR is an amazingly great modality in that there's no radiation and you get really great pictures, but the problem with it is it can only focus at one area well at a time. So if you want to look at the liver, which is in the abdomen, and you want a really good picture of the liver, you can only really take a picture of the liver that day. You have to do the pelvis separately. The other reason then people go, well, why don't you just focus the camera up here and then focus the camera down here? Like, you know what? I'm good. I can lie there for 14 hours if you want me to. I'm like Iron Man. The other problem is they can only give you so much contrast in a day, and it's also about timing. So when they give you the contrast and it goes through you, they're going to take the pictures at the time that it lights up best in the liver, but that time is not the same as the pelvis. And then they can't give you another dose that day because your kidneys can only handle so much. So that's why, I mean, again, Christian's not here. He'd probably answer it in a much more sophisticated way, but just to be simple, that's why sometimes you can't get it on the same day. I can tell you where, like, no one wants you to come back on separate days. But if we did it in one shot, so it's not specific, you're going to get crap pictures in both. So.
Let me just add to that. To be honest with you, though, I have to be careful. Pelvis is often not very informative if you're just sort of doing it out of completeness, unless like for neuroendocrine disease specifically, and if you have pancreatic or small bowel. The truth of the matter is that most of the time one has to sort of focus on where the most relevant area is and work from it. You know, if somebody has abdominal disease and it's progressing and you're worried about disease progression down into the pelvis, that's a different story. But to sort of do it, as, you know, sometimes I see patients ordered to have chest, abdomen, head, pelvis, and you can spend your entire life doing nothing but scans. That, in my view, is sort of extreme, and it's called what I call the all-inclusive approach. I think we need strategies that are much more focused and rational so that you're getting the most from that information.
Thank you very much.
First of all, I wanted to say thank you so much because the information is like patient, that exactly what we need, and especially with this disease. My question was for Dr. Khalili. Actually, he was talking about the MIBG screening, and you were talking about the treatment with the MIBG. And it's not available here in Canada yet. What about the GA data date? It's not here either, not the screening, not the treatment?
So the dotatate is part of what we were talking about with the gallium-68 to be developed here. So that's going to be for diagnostic purposes, and that's what we hope is going to come next year as part of the diagnostic component that will also involve lutetium for the therapeutic part of it. Yeah.
And it will apply for the tumors like mine, the on the neck, or no?
The answer would be yes. That would be qualified as a neuroendocrine tumor, and obviously the patient would have to qualify for the other entry criteria, but yes.
Thank you so much.
No problem.
No? We have a few online questions, so just bear with me for a second. Shorter ones. Okay, let me go back to that one for the liver surgery. This one here, yeah. Okay, so here's a question from online. I have numerous small carcinoids on my liver, original small bowel tumor removed in an emergency surgery. I'm presently being treated and managed, no physical symptoms, with 60 milligrams of sandostatin every 4 weeks. Would I be considered for liver surgery?
Okay, I'll take that one. So, you know, these are always tricky questions when you, well, to be honest, that's like maybe 10% of the information we use to make that decision. The very simple answer is yes, you would be considered. The whether you would or not is much more complicated. And I think that in the course of my talk today, I can't possibly go over that we have way more options than just liver surgery. There are things called embolizations. There are things called focal radiofrequency ablations. I mean, maybe another time, because I do enjoy coming to these. We might integrate more of those in the discussion. But the point is, of course, you'd always be considered, but there are a lot of factors that we use to make the final decision. The good news from what the information that was in the question was that you're under hormonal treatment, that you're under control. So that's a really good start, because when you've got that, you've got time to figure out what to do. You want to add?
Yeah. So the other, I think, fundamental principle that applies broadly not only to this particular question but to others is that neuroendocrine tumors are cancers that are really fairly dynamic. And more importantly, that the range can sometimes be anywhere from months to years or even decades. So the different therapies that we've talked about may be appropriate, but only at specific phases during the evolution of a disease. And what may have been appropriate at the very beginning may not necessarily apply now or down the road. So liver surgery in particular is very tricky, as Dr. Law mentioned, because knowing when to do it during the course of the illness is probably the single most important question. And it's a very relevant one.
Okay. The next question is, does anyone on the panel know why Neuroendocrine A and pancreastatin blood tests are not available in Canada? Is it too expensive? Do we not have the lab expertise to assay blood for these tests? Or when might we expect to get them here?
So these are fragments of a larger mother of hormones, which is chromogranin. So chromogranin basically gets chopped off into different components, and pancreastatin and neurokinins are components of that. The truth of the matter is, in the current era, where we have very good diagnostic tests, not only to measure chromogranin, but more importantly to measure disease progression by CT, MR, and other modalities, the actual ability of the tumor to secrete that particular hormone does not honestly add a hell of a lot more in the end. So for example, let me give you another extreme where you can have a very large tumor that is growing exponentially, and yet over time its ability to secrete the hormone actually declines as it has less of a differentiating feature. So if you were relying on a super sensitive assay, it can actually be misleading. At the end of the day, structure is very, very important, and I think that the structural imaging is crucial. Now, obviously, I'm very interested in peptides, and that the other end of the spectrum is it helps us in other areas. But for the average patient who's already diagnosed with a disease and is looking for disease progression, I would say that structural imaging, and particularly with CT, as you've heard earlier, is probably the single most important modality.
Okay, the next question. My original tumor was removed from my ileum, resulting in a permanent ileostomy. I have a carcinoid tumor sitting on my mesenteric artery and have been told it cannot be removed. Is this correct? Put you on the spot.
Okay, I mean, you know what? Again, unless you were to look at the pictures, it's pretty well impossible to answer those questions. And it's not to avoid it. It's because, you know, sitting on can mean a lot of different things.
Maybe you can elaborate on the issue of being adjacent to versus invasion of.
Sure. I mean, Shireen was just pointing out that, you know, sometimes it's a lymph node that's sitting beside something that's also described as sitting on, and sometimes it is something that's actually completely enwrapped around a blood vessel. You know, part of the problem is, and then when you said mesenteric vessels, there's actually many of them. But there are some main ones, some big branches in the mesentery that you cannot live without, okay? Like, I'll be honest. Surgeons can take anything out of your body. It's just that you have to actually wake up after the surgery, and so there are certain structures we just can't take out, right? Like, and I'm not saying that lightly. It's just, it's what it is a bane of our existence. There's many times where I can tell you we stare at a picture and we just wish we could operate, because actually sometimes the tumor is actually quite small. It's just sitting right there. It's so small, but it's just sitting in the wrong place that I hate to say it, but sometimes you have to trust us on this, that we know in advance that trying to operate there is going to be a huge risk, if not for sure risk, to your life, and that's when we have to back off. So anyways, the bottom line is it's almost impossible to answer that question without the picture, to sort of understand those nuances that we just talked about in terms of what to do. And that's why I'm so glad I worked as part of a team, because sometimes when I can't operate, then there may be other therapies that you should be considered. And not just the hormone therapy, not just octreotide. There may be other things, but again, it's all down to the picture. Yeah. So again, Shri was just telling me to talk a little bit about other energies. So one of them, for example, is radiofrequency ablation. You know, I'm a pretty simple guy, so if I were to describe radiofrequency ablation, it's like plugging in a cord in the wall with two bare wires and sticking them in you. So that's really what it is. It's just a little bit more sophisticated. It basically uses electricity to create heat that burns you. But we're starting to get other options, like, for example, we can actually stick a probe with a tiny little microwave in the bottom at the end of it. Well, that's still technology we're working on, but basically you can create a little probe that sends out microwave signals in a sphere or whatever shape you want. We're still working on that. That's been around for a while, but the actual technology to make it effective medically is still being worked on. So maybe one day we can just put you on 2 minutes on high. Not only is your pop ready, but you treated your tumor. So, but that's our dream, you know. So there are other technologies coming that might help us deal with that. The trick is developing a technology that preserves the good stuff and gets rid of the bad stuff, and that's hard. Right now, for some people, the technology of a really sharp knife is just not good enough for that. I'll be just frank with you. It just can't separate the good from the bad.
I'm just wondering, next year with the gallium and whatever might be possibly coming down the pipes, other than myself, who would be in the front line to qualify for that? Or how do you make a decision as to who gets and who doesn't?
So this is going to be part of a clinical trial. Every clinical trial has entry criteria that have to be met, as well as exclusion criteria. So that will involve many elements. But really, the intent here is going to be to make sure that those who need it will be able to get it, and will be able to get it hopefully in a timely fashion and in a manner from which we can actually learn so we can do it better, and not just simply deliver a therapy.
Okay, just so I understand, the gallium, because I've had the octreotide here,
Yeah.
and so you're saying that the gallium is better than that?
Yeah.
So the point of having the gallium would then be what? Like, so you find the spots, and then, so what?
So
then what?
There are two purposes for the gallium-68. So think of it as being your high-definition TV compared to your old tube TV. Its sensitivity and specificity is about twice as much. So it tells us two things. It tells us not only where disease is, but it gives us something that we can target to measure the effectiveness of a treatment. Let me give you an example. Sometimes we'll do a CT and we find 2 spots in the liver, for example. Then you do the gallium-68 and then you find that there are 8 lesions, not just simply 2. The gallium-68 gives you an idea also of how metabolically active those spots are. So when we deliver the radiation, we can then go back and not just look at the size of those 8 spots now, but rather what their metabolic activity has changed by the therapy. Okay? Because you may not see a change in the size, but if that tumor no longer is metabolically active, it is less likely to actually grow and cause problems down the road.
So I'm sure you understand that, but for me it's simple as this. That light bulb, it's on, it's one size. I can turn the light bulb off, it's still the same size, but it's off. That's what gallium tells us, whether it's on or off.
And then you would be able to decide better if that person would have surgery, or what would...
Well, in this particular setting, that trial is coupling the two together. So you actually get the gallium-68, and if it's positive, then you get the lutetium, and then you go back and you look at the areas that lit up on the gallium and compare them with those of lutetium and also measure the activity. So we're looking at the same bulbs and looking at the activity of the bulbs. It does not mean that, for example, down the road, if for whatever reason our lutetium radiation, for example, doesn't work, or if it works incompletely, then we recruit Dr. Law and say, you know what, spot number 8 is really giving us a hard time, so we better go in and take out that chunk of liver that includes spot number 8.
So sorry, one more question. So I've been doing this for a few years, and you've sent me off to a few embolizations. So when you get down the road to the better treatments, do I get disqualified because I've already had all this other stuff, or does...
Debbie, I hope not, because then you're going to come over and kick my ass. Sorry.
Do it.
I love that woman, but anyways, no, I do. But I honestly right now I don't see why that. I don't have the criteria in front of my head, but I have never thought of you as somebody who's had something that would preclude that. Okay.
I agree. I mean, we are cognizant that people, especially those in Ontario, have already received lots of therapies, including RFAs and embolizations and others, and that will not be a disqualifying feature. What we don't want is a concurrent therapy or one that has an overlapping effect that would preclude our ability to be able to monitor the response. So the $10 million question is actually to be able to produce it because it's got a very short half-life. The biggest problem with the gallium-68 is exactly that. It's actually 68 minutes. Within that, it's gone. So you have to make it and use it very quickly. And that's why you can't just simply buy it. And it's for that same reason that many centers, even in the U.S., deliver lutetium therapy empirically without doing gallium-68 or doing appropriate internal dosimetry. And that's one of the things that we're really trying to do here is, as I mentioned earlier, our emphasis has been not just on delivering a treatment, but doing it well and doing it better, hopefully, in learning from all of the experience that has accumulated over the years in Europe.
Are giving me the reasoning of fatty liver. Is it possible that the fatty liver could be misdiagnosed?
Okay, so the simple answer is probably not. If they told you you have a fatty liver, you have a fatty liver. Sorry. The issue with fatty liver, though, to be honest, is that it can hide other things. So with a fatty liver, the CT scans, for example, won't be as accurate. But it's accurate for the fat. It's just things inside your liver might not be able to see as well. So sometimes you have to adjust the imaging.
I did not have a CT. All I had was an ultrasound done, and they gave the possibility of fatty liver. They didn't even verify it in any other way. So.
Okay. I mean, okay. So I don't know what the ultrasound's for, and I don't want to ask. But if it was just a screening ultrasound, you're not looking for something, and they make a comment that you might have fatty liver, that's something that usually it's not wrong. It's just probably your borderline rather than, it's not like really, really, really fatty liver. It's just a little bit, and it makes it hard for them to sort of scale it because we don't have a scaling system. But if it's just an ultrasound you're doing for no particular reason, then, you look at that and you take that information, and it's not dangerous. Your liver's not about to fail, but it means, probably giving you a hint about being a little bit more fit and losing a little bit of weight. Now, remember the liver, I'll tell you, the liver is an interesting thing. The first 10 to 15 pounds that people lose, and sometimes their clothes don't change or anything, you actually lose it all out of the liver. That's a good thing. So I always tell people, even if you have a mild amount of weight loss, it can help your health a lot. So what I was mentioning about the other stuff is if they were doing an ultrasound to look for something, and they mention that you have fatty liver, just know that the fat may interfere with the ability to find that spot. If they were just looking at your liver in general, it's a totally different question. Okay?
Okay. They were looking for something and didn't find anything other than they're still looking.
They're still looking. Okay. Well, look harder.
I just had a thought, actually, just maybe Louise, you reminded me. I actually think that next time we're having a series of these, we should probably have a focused discussion on imaging of the liver, benign and not quite so benign conditions, because this is a very important question. There is a spectrum. Dr. Law has done a wonderful job at answering your question. I totally agree with him, but I want you also to be aware that, there's so many things that go along with fatty liver. It's a very common problem. There's diabetes, and we have hemangiomas, and there's so many things within the liver. So I'm going to remind Louise, because I'm now getting to the point where I always forget.
The only other thing I would add is the worst thing for patients, especially this group, is that as our imaging gets better, we see everything. And so you start not even knowing what half the words mean, like hemangioma, focal nodular hyperplasia, cyst, mesothelial cyst. It just goes on and on. And our job is to try and explain to you what's important and what is just like a freckle or something, because some of them are not related to this at all. But it is a torturous time if you just read radiology reports. And like we torture ourselves at Sunnybrook, right? Because we opened all your medical records to MyChart, so you can look at every film report you've ever had. You can look at it exactly the way we wrote it. You can read my notes when I say, "Oh, it was really difficult today with Debbie." No, I didn't say that. But she can check it, But the point is that it's really important to communicate with us, because we want to be transparent with you. We want you to see it all, but it can scare the living bejeebers out of you when you don't understand what all the little words mean. But you got to understand that we're also pushing our radiologists. We want them to tell us every single little thing about the liver, because we're the ones that interpret it for you. But if you just read it raw, just take a breath. It may not be important at all. Just make sure you talk to us, that we can explain it to you. Okay? Because it hurts. It hurts either way we do it. Either we don't get enough detail, or we get so much detail that without an explanation, it looks really scary.
God bless you, because I wish there were more doctors like you down
there. Okay. My question is, is it common for people to be denied of critical insurance claims if the disease is picked up early? Like in our case, it was a proliferation index less than 1%, KI67, and we were told that it's benign, so insurance claim has been denied. Is it a common situation that others are finding?
You're raising a very important and relevant question. It applies to many other parts of a body, including the thyroid is a very common area, even the lung, the breast, the prostate, the skin even. So the truth of the matter is that most insurance companies now have a provision where they're required to obtain more information in order to know what is the likelihood that the disease has been A, cured, B, to come back, and C, whether there's going to be a surveillance plan specifically targeting this disease. So your physician has to be appropriately, I don't want to say preempted, but you should have a discussion with your physician to make sure that the relevant and appropriate information is transferred in a manner that doesn't undercall but accurately really reflects the disease, so that when they're really assessing the case, they're able to put it together, and then you have an opportunity to appeal it if the response really is suboptimal.
Thank you.
Any other questions? Okay.
How helpful do you find capsule endoscopy for finding small bowel tumors? Do you find them helpful at all?
Okay, so I'll respond first, and Dr. Law will tell me at the end whether I was right or wrong, because he's the one who ultimately ends up getting there. So the capsules and cameras and all these other sort of technologies are really sort of still relatively within a small area, not terribly useful yet, because we haven't been able to do the systematic studies to be able to compare them to a gold standard. So anecdotally, when you do them and then you find all sorts of spots, ultimately when you go back, you really have to do something in order to verify whether that finding is real or not. So what we really need is systematic studies that prospectively compare them head-to-head with something that we consider to be validated and worthwhile. In my experience so far, specifically within small bowel, they haven't been that good.
So, a good question. Capsule endoscopy, it is an important type of investigation, okay? Important enough that it's actively on the board for the Ministry of Health to discuss about how we're going to cover this for people, whereas before it used to be charge only because they didn't even know about it. But for neuroendocrine tumors of the small bowel, I'm just going to be frank, like a capsule endoscopy is not that helpful. It may find the tumor, that might start somebody on a journey. That might not be such a bad thing. But in terms of the definitive planning of your treatment, there's no way a capsule endoscopy is enough, for example, to plan your surgery. As the capsule floats through you and takes pictures, somebody analyzes, they might see something on a given picture. And even though the capsule tries to remember where it is, it's like that really bad GPS that keeps recalculating. It really doesn't know where it is. It really doesn't. And I can tell you that if you had a capsule endoscopy that suggested you had a small bowel neuroendocrine tumor, I don't think Shireen and I would believe it. What we would do is to do a CT angiogram or other tests to figure this out. But the thing is this, if you back up a step and say, why did you have the capsule endoscopy if you've had repeated sort of the correct symptoms, etc., as an Ontarian who's proud of a public health care system and I want to spend our money wisely, I would have said, gee, if you have the right symptoms, you should just got a CT angiogram. I mean, right? Yeah.
Any others? Last chance? Okay, so I guess that's the end of our formal our Q&A. A huge round of applause for our doctors, please. We'll thank Dr. Kalali and Dr. Singh separately since they had to leave, but thank you so much. You know, these guys take their personal time on their Saturdays to spend with us, so we really, really, really appreciate it. Thank you. So for those of you who might not have received our handbook yet, there's free copies on the merchandise table, so make sure you grab one on your way out. And don't forget about our breakfast on November the 10th. It's bright and early at 7 o'clock in the morning, and Dr. Zat will be speaking there, presenting that day. And I guess I also want to thank Louise again for organizing this session, and for all the volunteers that have volunteered today to man the front desk and the merchandise desk, and also to Enrico for managing some of our technical requirements. And I'm just about to get there. And I also want to thank our sponsors, without whom we would not be able to hold these sessions. And we have so many sponsors now, I don't want to leave any of them out, so I have them listed here. Pfizer, Janssen, Pendle Farm, and Lexicon. So thank you, everyone. I hope you enjoyed the session. And this will be available. Not sure how the audio is going to be on the on-demand version, but it will be available online. Thank you. Oh. Sorry, I did forget one thing, the evaluation forms. If you don't mind filling them out for us and just dropping them off at the merchandise table, that would be great.